Good morning, everybody. I think we are now live, and just to confirm and remind everybody that we are being recorded as well for the meeting to be available to members of the public and colleagues and governors who wish to watch it back. I do also welcome everybody to our board meeting for our last board meeting of this financial year, actually. Welcome to everyone. Particularly wanted to welcome governors who I know are observing us today. I understand that governors include Chris Davison, Joanne Darren, Paul Smith and Al Richards, so a warm welcome to them. And I also want to welcome Dr. Helen Lewis, who is observing us today as part of her development, I believe, Helen. So welcome.
Thank you.
We do have a few apologies. So we have apologies from Dr. Itai Matumbike as medical director, but Banu is ably stepping into his shoes as he has been now for a couple of weeks. We also have apologies from Linda, our deputy, our director of nursing, AHPs and quality, and also Joanne Lancaster, who is our new associate NED. Unfortunately, she couldn't join us for this meeting, but she has officially started, so I wanted to note that. I think that covers everybody who's given an apology. We do have a couple of people who just need to shoot away or be away at the beginning of the meeting for a couple of key meetings that are taking place, but will be joining us shortly. So I believe Chris Oakes and also Anne Rackham will be with us in due course. So that covers, I think, everything I needed to mention at the start of this meeting. So we can get cracking on our key items. So actually, just also to note, any declarations of interest beyond what we've recorded on the register. I think I have a note that Robin and Chris have updated theirs, but probably those aren't in the updated version. But unless there's anything specific to items on the agenda, I think we probably don't need to be too concerned about that. Banu?
Apologies, I have sent my declarations yesterday, so because I wasn't about the meeting, so I will add them onto the minutes.
Okay, that's absolutely fine. Thank you, Banu. Okay, well, we'll move on to the minutes of our last meeting, which was the meeting of the 26th of January. Can I just check with colleagues whether there are any points of accuracy, first of all, relating to the minutes? Is everyone then content, that's paper A, that the minutes are an accurate reflection of our meeting so that we can sign those off? Yeah, okay, thank you very much. So we'll approve the minutes. We do have an action sheet. Before I cover that, any matters arising that aren't covered on the action sheet from the minutes? Yeah, I'll take that as a no. So paper B is our action sheet from our last meeting, and it obviously includes actions that we may have carried over. I think the two actions that were due for by this meeting have been closed, and the others are in fact actions that are being continued onto the Quality and Safety Committee in April. So I'm not proposing that we discuss them in any detail at this stage, but does anyone want to make any comments about the actions? Okay, so I think on that basis, we can just note the action sheet and the position on those. And there is actually, the proposed changes to the Constitution, Richard. Oh, that was actually completed as well, wasn't it? So that's fine.
Yeah.
Thank you. Thank you very much. So paper C, before we move on to our patient story, is our Board of Directors annual forward plan. And that really just sets out the items that we're expecting at future board meetings and the regular schedule that we have. So if there's any comments on that, there's an opportunity for us to take them now. Otherwise, I think we're ready to go on to our patient story. Okay, so delighted as ever to focus on a patient story at our board. I think Jean, as usual, will introduce this. And it is a story about our sexual assault referral centre. Jean.
Thanks, Krishni. So I'm really happy to have Faye with us today, who is the manager of the SARC in Northamptonshire. They offer amazing support, care and real dedication to people who are experiencing very traumatic events. Without due course, I'm just going to hand over to Faye. She's going to read out a patient story because obviously due to sensitivity of the service itself, we're unable to have somebody with us. So I'm going to hand over to you, Faye. Thank you for coming today.
Hi, good morning. So for those of you who don't know me, my name is Faye Wickett. So thank you for the invitation today. I'm the manager of Serenity, and I've been the manager of Serenity for 7 years. It's not widely known amongst the NHFT community, but it's actually been part of it for 12 years now. So Serenity is Northamptonshire's Sexual Assault Referral Centre. It's also known as SARC, 24/7 healthcare provision. It provides a safe space and a dedicated care for anyone who's been raped, sexually assaulted or abused. We offer a range of services including crisis care, medical and forensic examinations, emergency contraception and testing for sexually transmitted infections. We also offer aftercare support of independent sexual violence advisors, also known as ISVAs, as well as referrals to mental health support, voluntary sector sexual violence support services. We will see anyone in Northamptonshire, men, women, young people, children of all ages, and all under 18s from Leicestershire as part of the East Midlands Paediatric Sexual Assault Service. All our clients are treated individually as everyone's experience is different. What is important to us is their well-being, regardless of sexual orientation, gender identity, ethnicity, religion, and most importantly and fundamentally, our service users' choices. So the service user's journey that we're going to talk about today is something that happened in 2018. And for the purposes of today's presentation, we're going to call our service user Millie. The journey for our service can be quite a few years, depending on recovery, criminal justice process, court dates, and things like that can influence the time duration. So on the 27th of December 2018, Millie was subjected to a prolonged and physical and sexual assault. She's a 46-year-old lady who had been in a relationship with a perpetrator for 6 months. It initially was quite a happy relationship until some elements of cohesive and controlling behaviour started. Millie had asked the perp to leave a week before Christmas, but he turned back up at Christmas Eve. Had quite a good Christmas, then a series on Boxing Day, a series of sexual offences happened over the next couple of days. Millie at one stage had a knife held to her throat and was made to carry out several acts. She eventually asked the perpetrator to leave, which he did, and then he drove his car in anger into her house, destroying her kitchen that she was in at the time. She ended up with an injured leg. She managed to escape by hiding in a bush in her garden at her house. The police were called. She disclosed what had happened over the last few days, and then she was referred to Serenity on the 28th of December 2018. We arranged an examination with Millie with a female physician at 3 p.m. on that day. So the examination process initially is a fact finding from the police and most importantly from Millie. We ask about assault, injuries, healthcare needs. This will help formulate sort of judgment on what forensic retrieval that the physician will have to undertake. We also assess for injuries and body map if there's any. So after the forensic retrieval, we will discuss about contraception, HIV and hepatitis preventative medications. Then discuss aftercare support considering mental, social and holistic needs of the service user. For Millie's examination, we collected 14 forensic exhibits during the examination, which was handed over to the police for DNA analysis. Millie had multiple bruises and significant swollen foot, so we arranged for the CSI, previously known as SOCO, to come and photograph her injuries here at Serenity, and then we referred her to Northampton General Hospital for an X-ray on her foot. So aftercare would look like, so we referred to the integrated sexual health team, and she accepted a referral for our emotional support workers of the ISVAs. So Millie was at Serenity for her forensic medical examination for 2.5 hours. She fed back that she felt safe, listened to and believed. My colleague Gillian, who's going to be talking next, is an ISVA who supported Millie and will continue the story.
Hi everybody. Is there any questions before we move on?
Okay. Do you mind just saying, not everyone might be familiar with the term ISVA, so do you want to just remind everyone what that is? Thank you.
That's me, that's what I am. I'm an ISVA. I'm an independent sexual violence advisor. Does that make a little bit more sense?
Yeah, that's lovely.
Okay.
Thank you.
So my role is to work with people who have been raped or sexually assaulted. The level and type of support, plus the length and involvement, can vary from case to case. And this is not an off-the-shelf approach to support. It's tailored to individuals' needs. It generally involves providing emotional support and advocacy on behalf of the client. So Millie was referred to me in December 2018, and that support concluded in May 2021 after a court case. So it's quite typical for court cases to become long, drawn out and protracted experiences for clients, and not always successful, unfortunately. It's also very scary, as most people have never had to be involved with the police or court in their lives before. So my initial work is to conduct a needs and risk assessment and review safety plans. I also take into consideration any other issues such as care and needs, family intervention, any other support provided, etc. So Millie came to me. She'd been subjected to oral, anal and vaginal rape from her ex-partner, plus extensive physical assaults, as we've heard, but also to include attempted strangulation. It was clear from the outset that her immediate need was for emotional support, as I'm sure you can imagine. She was suffering from fear, isolation, depression, guilt, shame, flashbacks, lots of things. Just imagine what you'd be going through if this had happened to you. As well as the emotional support, Millie had to deal with going to court, something had never imagined that she would ever have to do. A very scary situation where she thought she may have to come face to face with her aggressor. During this time, I continued to review her risk and needs assessment to identify exactly where her concerns lay. And we agreed a communication plan as to how often we would meet up and whether that would be face to face or over the phone. And for example, part of my role was to ensure that she had a court visit beforehand, so that she could acclimatise herself with the court. So we went in during the lunchtime when it was closed. There was nobody there, so we could have a walk around, and I could show her, well, you're going to stand there, that's going to be there. She was also granted use of what they call the back door at court, where she could use a different entrance to that of the defendant. However, the court didn't do a risk and needs assessment, and she was still using crutches. So this was not accessible to her on crutches. So I intervened and liaised with the court, and we made alternative arrangements for her to be able to come into the court without seeing the aggressor. I was also able to attend court with her so that she would have a friendly face that she could relate to. Millie would often tell me that she didn't think the police or courts cared about her, that she was just another number to them, and she wasn't kept up to date with the developments till the very last moment. Letters were sent to wrong addresses, dates for hearings, and the results were not communicated to her. She could never get hold of the officer dealing with the case unless he wanted her to do something. She stated that the only constant throughout her ordeal was me. And other quotes from her were that I felt that apart from Serenity, I was thrown to the wolves. She said, I wanted to see him suffer like I had to, and it was Gillian who helped me through this. She said that she couldn't have gone to court without Serenity. She wouldn't have been able to face court without Serenity to support her. And at the end, she said that it was a truly heartfelt experience, and that she celebrated us and thanked us for our support. So it was a very, very hard journey for her. And in conclusion, I think we provided a complete report to court experience. We assessed her health needs from the start by assessing her risk to sexually transmitted diseases and pregnancy and other health issues. We identified physical requirements and signposted her onto the appropriate professionals. We identified her specific needs emotionally, but also practically as well. And we listened to her. And I think that's the biggest thing that she said at the end of it. We actually listened to her and cared about her. And we acted on her experience and needs, which of course were constantly changing throughout those years. We also helped her access some compensation. There's a thing called criminal injuries compensation, which is set up for victims of violent or sexual crime, which she didn't know anything about and the police didn't tell her about. So I helped her with her application, and she did get some financial gain from that. Her aggressor was found guilty at court, and she now continues to improve and flourish in her new life.
Thank you so much, Faye and Gillian. That really, really brought to life the service that you provide, and obviously, you know, incredibly harrowing experience. And I think supporting Millie through that, you've obviously done an amazing, played an amazing part in that. Are you comfortable? And Faye, lovely to see you again. I've had the pleasure of visiting the service not that long ago, actually. Jean and I were there last year, I think. So it's one of the first services I was able to go back and visit after the pandemic. So really good to see you and have you here talking about what you do and the really, really important work that you do. Are you comfortable to take some questions, both of you? Because I know the board's always very engaged and in wanting to understand more. So there's quite a queue of people wanting to come in, if that's okay. So first of all, Melanie, and if you wouldn't mind, colleagues, just to introduce yourself when you're asking your question.
Hi, I'm Melanie Hall. I'm one of the non-executive directors for the Trust, and I thank you for your story. You clearly talk us through all of the detailed and many services and support that you offer the people who come through your service, and it sounds like a very broad and essential service for people who've been through these traumatic experiences. I wonder how, if you could just help us understand how you yourselves protect your own health and well-being as you deal with cases that must be incredibly difficult for you to handle and manage and sustain yourselves through. So I wonder if you could just tell us a little bit about how you look after yourselves.
We question this ourselves most of the time, if I'm honest, Melanie. But it's all about regular check-in, supervision, making sure that we separate life and business, quarterly safeguarding supervisions, meetings with police, meetings with social services. We just check in, we speak to each other daily, we have a forum. I have an open door. And I know a lot of people say that, but I literally do. Anyone can come and have a chat to me whenever they want. Anything else to add that I've missed?
Well, I just said that Faye's a very good boss, and she does literally have an open door, and we can come and speak to her whenever. And we also work in a peer group as well, so that if I have a difficult case, I can go and talk to one of the other members of staff, and we can share ideas and say, well, how would you have dealt with that, and have you come across that before? And yeah, we just cope with it.
And what's also really handy is we have like a very close links with the safeguarding team, so we could literally just ring and say, we've got this situation, can you help us or give us advice regarding that? And that works really well as well.
Thank you very much. Saqib.
Thank you for sharing what was obviously, you know, very, very painful and harrowing for the user involved. I just wanted to say that having just read case files when I was with the police in a previous role, you know, that was, you know, very harrowing itself, but to actually be living through it daily, all I can do is I think thank you for the lengths that you go to for helping these very vulnerable people at a time of great distress. Yeah, it was, obviously it was difficult to hear what was being said to us, but thank you for sharing that, and I just wish that user well. Thank you.
Thank you, Saqib. Angela?
Yeah, thanks, Faye and Gillian. Good to see you again, and just to say thank you for what you do. I've been lucky enough to be on the journey with SARC for the 12 years, so it's great for me to see how it's come on, and also with your leadership, Faye, how it is developing even further. I was really interested in what you described, the tailored approach, which I see as person-centered approach, and I think that's what struck me in abundance from what you described. I was just interested in why you felt, or it came across to me, that other agencies were less person-centered, or perhaps that was the perception from the individual, or is that your reality? I'd just be interested in that, please.
I think other services that are involved they've got a very prescribed route that they have to follow, and they don't deviate from that route. Whereas I'm looking after a person, and I want to see the best for that person. So I don't have a book of procedures that I have to follow, and there's no steps that I have to go. Well, there are obviously some, but there are no steps that I have to go through to fulfill my role. What I'm doing is fulfilling what that person needs. And other people, like the police, I'm not trying to diss the police or anything. The police, they do a very good job. They've got a lot to do, as I have, but they follow a procedure and they stick to that procedure. And they're not trained in dealing with people as people. They're dealing with crimes. And the people at the court, they have to get the court ready at 8 o'clock, and they have to get people in, and they have to get the people out, and that's all they think about. And I'm not trying to put them down for that, but my role is different. I'm more, as you say, more person-centered, and I have to think outside of the box to make sure that they can cope with all of those things that are being pushed on them that they have to do.
Lovely. Thanks, Gillian. Thank you.
Thank you very much, Gillian, for responding to that. I did wonder, I mean, if I may, just on the back of Angela's questions, because I think there was a conversation about using a video at one point, but I think it was a training video for the police. I mean, obviously it's difficult to talk about a specific case, but if there is learning that we see, because we're dealing very closely with, we're supporting an individual, are there mechanisms for sharing that and giving that feedback?
Yes, we regularly give feedback to the police about our experiences of working with them, and pass on the feedback from our clients. And I have to say, they're quite open to listening to us. We do a lot of training with them on our role and what it's like to be a victim of rape and sexual assault. So we try, yes. Yeah,
thank you very much. Julia.
Thanks, Krishni. Thank you so much, Gillian and Faye. That was incredible. I'm Julia Curtis, one of the non-exec directors, and my question's been answered already, but I just had to say, if we were looking for an example of true compassionate care, and you ooze it, absolutely, and the words I've taken away from you are around people feeling safe, listened to and believed. And I don't underestimate, what that takes to help somebody to feel that. So thank you for everything you do. And I think you're incredible people, and I'm sure the whole team. So thank you very much for sharing with us. Really, really important that we listen, and you've brought that to life for us. So thank you.
Thank you. Appreciate that.
Thank you, Julia. Robin?
Most of the points have already been made, and I just wanted to repeat them again, really, to say thank you for the work that you do, and the incredible value of what you're offering to victims. But I wanted to come back again to Angela's point about the work of other agencies, and we know that the prosecution rate, if not the conviction rate, for sexual assault has now dropped to a kind of all-time low, to the point that most women and victims don't get access to the court, don't get their cases brought to court. And that must be enormously frustrating for you too, and the people and the women and others that you work with. And I just wondered, as as Neds like me, how we can support you in terms of trying to help bring justice to more victims, and whether that would be of use to you and help to you.
Sorry, Robin, what was your role?
I'm a Ned.
One of the non-executive directors, yeah.
I'm not sure, to be honest with you. I think it is very difficult getting cases to court. This case study is an unusual one because it did go to court.
Yeah.
I think what we need to do is broadcast more about what we do and the frustrations that we deal with, and hopefully people like you with your experience can help us with that. I don't have an answer to that, Robin, I'm afraid.
I would say from my perspective that not everyone is aware, but you don't necessarily need to come via the police to be referred to us. We have a self-referral procedure. So that's quite a handy mechanism for somebody who's not quite decided what they want to do in the long term, but at the same time we address the emotional and healthcare needs. And then at the tail end, we can store forensic evidence. And then the service user has 2 years to make their mind up if they want to convert. And then we can send the swabs off accordingly. I think a lot of people drop out at the initial report stage. So I'm trying to do, and I've been trying to do this for a couple of months, but I will win this. I'm trying to do this piece of work with the police where our staff go out with them on initial calls, and we will separate the sort of criminal justice side to the medical side. So we can clearly be separated away from the police and explain what will happen and how we can look after people's needs. Then the police can concentrate on the criminal side. So that is what I'm aspiring to. So if you see any police and tell them that it's a really great idea, I would appreciate that.
Faye, that's such a powerful point. Thank you very much. I do, I think if I'm right in hearing what you've said, I think it's really important that the really important point seems to be to encourage people to come to you for the support that you can give. Whether they then choose to report it is a separate issue, I think, is what you're saying.
Yeah.
So it's the support that you provide that is really, really important. And actually, they've got time to make a decision with that support.
Yes.
As to whether they wish to go through a formal other process. So that feels quite important in understanding that about the service and about making sure we encourage people to access it, because once they've had the support, they might feel differently, I guess.
Yeah.
Is that fair, Faye? Is that an accurate?
Yeah.
Yes.
And
Okay.
I think we're honest with them as well from the start about what the journey is, because the police might be rushing them into doing something because they need to get it finished.
Yeah.
And we're honest about, look, this is how long it might take and this is what it's involved.
Yeah. Thank you. You've sparked so many questions and thoughts that there's still a few more people, but I'm going to take the hands that are remaining, but I'll stop at Jean. So no further sneaky hands, please. Otherwise, I think we'll be keeping Faye and Gillian here for all morning. Otherwise, Julie.
Thank you, Krishni. Thank you very much, Faye and Gillian, for such a compassionate and caring story. And thank you, Faye, to all your staff as well, if you could pass on our thanks. My ask is, I've got an ask of you, hopefully. So you said right at the beginning, you're a little known service in the trust. Well, I've got an opportunity for you to share your story if you would be interested. So we've got the Nursing and AHP conference on the 15th of May, and the subject is compassion in practice. And I wondered if you come and do one of our sessions for us and share it with members across the trust, because I think your story just fits what the conference is about and what the trust is trying to do around compassion. So if you are interested, please do contact me. I'd love to get you involved in the conference.
Yeah, lovely. Thank you.
Sounds like a really good opportunity to let people know about what you do, Faye. So we'll let you liaise with Julie on that. Thank you. Banu?
Thank you. I'm Banu Chadlwala, Deputy Medical Director of Professional Standards and Acting Medical Director. Firstly, wanted to acknowledge that this is very essential piece of work which you're doing. I guess it's very hard to plan, but shows how important the work is. My ask is very similar to Julie's. because when you're taking a psychiatric history, you do ask these questions to get kind of what the trauma is, how it is related to the episode, and how the adjustment is. But I don't think we have that level of kind of, in some ways, the training or coaching to kind of follow up these questions. So some of these questions, it can kind of trigger quite difficult memories, and then it can affect the subsequent into. I mean, when I say the how the services are perceived as well. So it'll be really helpful, say, with your experience, if you can come and talk to the junior doctors, and I guess we all will be there. We'd say it's a learning for all of us to kind of see, because of the experience you have, how to ask these questions and what support can be offered. And it's also be helpful to know if you're seeing somebody on call that this has happened recently, they're in a crisis, to know kind of what support is there. I will, if it's okay with you, I will kind of send you an email. But one thing I can confirm is we used to work opposite each other, and that open door policy has always been there. When she was with the SHO outreach team, but thank you.
Okay, no problem.
Thank you. So that sounds like another invitation,
It
Faye,
does. We're gonna be busy,
to
aren't we? Yeah.
you are. You are. Okay, and then finally, Anne and then Jean.
I'll be very quick. Thank you, Faye and Gillian. I, like Angela, have been along the journey with SARC for many years, and I know when you walk into SARC and into Serenity, there is what you wouldn't expect for something that has to be very medical, but a real sense of warmth and safety. And I think that's what your service users are experiencing, and the ability for the team to work with adults at one moment and then a child in another moment is really quite amazing to be part of and to observe. I think one of the things that's important for us to keep reminding ourselves, we have a number of contracts with the police and the courts through the services that we provide, and how we continue those messages and keep them joined up to support the victims, because a lot of our other work is about perpetrators and it's about ensuring we get that balance. So let's pick up your thoughts, Faye, around what can be really helpful. I really like your ideas. So let's get that into the contract meetings, the partnership discussions. And we are having a deep dive at the MHLGA collaborative around partnership and police. So I think it'd be really important to get this into that as well. So thank you.
Great, thank you, Anne. And finally, Jean.
Thanks, Krishni. So Faye, and obviously I'm a big fan. But I just wondered, last time I came out, we were talking about health inequalities, and your referral numbers have increased quite significantly since COVID, but you're not seeing the numbers from perhaps some areas of the community, men in particular, and some of the people with different ethnic backgrounds. So I just came back to Robin's point, really, in terms of how the board can help with that. And I'm just asking colleagues if they're in any meetings, etc., across the county, to always consider the Serenity service and the fact that we do need to get the message out there to different areas of our communities. Just one point, Krishni, please, for some support from the board. Thank you, and thank you, Faye and Gillian.
Thank you.
Thank you, Jean. I think we'd all absolutely support that, but we just need to look for these opportunities continually. And actually, I think, Faye, hopefully you found that just by presenting here today, actually people are, it's sparking thoughts about how we join these things up better and make sure that the learning from these different services that we offer can be shared. And your point about partnership with the police and how you work maybe slightly differently, so that we can make the people that need it can make the most of the service you offer, is, I think, a really important one. There's some lovely comments in the chat, and I won't go through them all, but I just want to pick out that David Williams has commented, who's our director of strategy and partnerships, that the importance of reminding our communities and stakeholders of the breadth of services that we provide, because it's not always, services like this, which are very sort of special and have a very and maybe because of the nature of the service, we're very sensitive, aren't we, to people's confidentiality and privacy, that sometimes it may actually keep the breadth of what we do below the radar for people, really. I also just wanted to mention Scott Adams. I don't know if you remember Scott. I think Scott and I visited together some years ago, if I remember. And Scott's on the screen, and he's just said how much he valued that visit, and just wanted to add his thanks. Lots of lovely comments about how amazing the work you do. So I think we've all been moved by the story, that Millie's story, and the positive that she felt so well supported by you and everything you do, and just really recognising, I think Melanie made a really important point at the beginning about our support for you in providing what is clearly quite a difficult service for the people who need it. Just wanted to thank you on behalf of the board, and appreciate the time you've taken to come and talk to us. I think it's a really been a positive opportunity to reflect on what we can do to support you. And I think Anne's point about, and Julie and Banu have made some points about how we can perhaps feature more about the service going forward. So thank you, Faye. Any final comment from you before we let you go?
No, just thank you for the opportunity to come and talk about us.
Yes, thank you for listening to us.
Thank you both. Lovely to meet you as well, Gillian. Take care.
Thank you.
Thank you. Bye-bye. Okay, really great opportunity, I think, Jean. Thank you for organising that. I'm really glad we managed to get that on our agenda. So we move on to item 8 on our agenda, which is the risk section of the agenda. So we've got paper D, which is our organisational risk register. We have got Chris with us, so over to you, Chris.
You're on mute, Chris.
Thank you, Krishni. Yeah, as we said to the board, we had undertaken a risk workshop with the Strategic Exec Board and looked at the key elements we've identified in the paper. The improvements to our overall practice, looking at the joint committees, reviewing the risk outside tolerance, looking at our approach to board assurance, and looking at the top risks. It was a very positive workshop with a lot of in-depth discussions, and we thought about what we should think about in terms of starting, stopping and continuing with the current approach to risk. We discussed the joint committees in depth, and there's a paper later in the board, so I'll come to that when we get there. We looked at the risks outside of tolerance and quite a lot of change in that, which is described in the paper, so I won't go through that. And we also discussed in depth how we might strengthen the board assurance, and we're thinking that it may be helpful to think about moving more towards a board assurance framework linked to the corporate risk register, and to look at that in our next board workshop and consider how we take that forward. So again, I think that's a positive indication of things we're considering. Then we looked at the top risks. B4, there is an issue here with the changes in the framework, the overall organisational change in terms of our data, and particularly in System 1. So we've got a real programme of work there led by Jean to look at how we can bring that into line and address that risk. So it's a major piece of work being undertaken. And on the workforce risk, again, we are really trying to explore what kind of innovations we can develop potentially with any new technologies, but also Derbyshire have done a lot of really positive work, and we're reaching out to them at the moment to look at the approaches they've taken and share that. Then listed out the changes within the ORR, and the key actions that we're taking forward are also listed. And as part of that, we will be, as we said, looking at the BAF, looking at a new exec risk group. So can we actually take more time to look at that within the exec group and how we move it forward? And then finally, we've set out the system risk position. So really for the board to receive the ORR and assurance that risk is continuing to be managed effectively, and that we will take all the actions forward that emerged out of the workshop that we've undertaken. So if there's any questions on the paper or any questions to the risk owners.
Thank you very much, Chris. So first question from Judith.
Good morning. Thanks, Krishni. Chris, thanks for the paper. I've got three observations or questions, depending. Firstly, with the suggested move from the OR to a BAF, I am familiar with both, but clearly I'm quite interested in what the executive team feel would be the benefit of it, because there are pros and cons to each type of risk management process, but it's something that clearly would need, this discussion is not the appropriate forum. I'm looking forward to the workshop on that. Secondly, these are risk-specific questions. The first one is in relation to B4, the data accuracy. Again, not sure if this is the appropriate forum, but we weren't able to discuss these changes at committee because they haven't yet taken place. I'm obviously quite concerned by the change, the sudden negative change to this risk. And we'd like to understand a little bit further. Not sure if this is an area for a deep dive at one of the at the joint committee, at the new joint committee, which I now forget what it's called. But obviously, I'm quite driven to understand how complete, accurate, and timely data is achieved in our database. And finally, D6. I'm not sure I quite understand the way that the risk has been rewritten. It refers to a lost opportunity if we don't benefit from partnership working. I'm not sure how we would identify that lost opportunity. I mean, how would we know, and how can we mitigate against that? It's quite an interesting sort of thorny issue, and again, happy to discuss this at committee level or offline. Thank you.
Yeah, so the first one, Judith, I think in terms of BAF, I think we are thinking how can we align even more to the strategic objectives and review that, and it's very much a CQC focus. I think you're right, this isn't obviously a completely resolved thing. We need to take that into the board workshop, but I think it's good to look at it and review it and see the benefits of both approaches. And I think it's showing, as we've talked before, continuing to review is important. I think on the specific risks, again, I think you're right, they probably are for the level 1 committees, but I don't know whether Jean and David want to just give any headline response to what you've said.
Sorry, Jean's got her hand up.
Jean, do you want to go first?
Yeah, so you're quite right, and the reason the risk has increased in terms of rating is because we've identified some issues that we absolutely need to address. We have now a very detailed action plan and working group focusing on that, and we've identified 5 themes of the cause of some of the data quality issues, some of which came out due to the changes we made during COVID. And Julie is also doing a thematic review on that from a quality and safety perspective, which is really important that we look at it from lots of different angles. Really happy to go into a deep dive on that on one of the committees, Judith, because I think it's important the board are aware of some of the issues that we've identified and what we're now putting in place to resolve those.
Thank you, Jean.
Thank you, Jean. I'll come back on that in a moment, but I think does David want to comment on the partnership one, David?
Happy we'll go away and think and have another look, but the principle behind this is partnership working is absolutely core to everything we're doing. You know, Patient Stories just taken us through some really good examples of it. The challenge for us in making sure that we continue to focus on partnership working is it takes us into a space where we get new opportunities and ways of doing things. If we don't do that well enough, we could lose an opportunity to build our breadth and our way of working, and that was the bit we're trying to reflect in the risk. I think very previously we had a different way of articulating it, and previously the way we articulated it was partnership working might slow us down, and that's my very abridged version of it, and felt actually that's fundamentally wrong of what we're trying to do. What we're trying to do is to build and do it. We've got to be clear that if we don't, we could lose opportunity. So that's the principle we're trying to work through, but happy we'll go back and think about it.
Thank you.
Thank you, David. Before I bring Julie in, I'm just sort of wondering, look to Richard and Chris on this. I mean, obviously there's a bit of support for the idea that this B4, the timely and accurate data, warranting a deep dive. And it seems to me, I mean, clearly that it affects our performance data and it affects our, potentially quality as well. So it does seem, I wonder whether it's an area that we might look at within the new Integrated Assurance Committee, I think is the the name that we are proposing. But I don't know, Richard, whether timing means that we what's the best timing for doing that, whether that needs to come to there is a planned committee in May, isn't there? But I don't know whether actually that's the most timely, or whether we should do need to do a bit more work on the risk and then bring something to the next meeting. So any thoughts on timing of that, and whether that would be an appropriate topic for the Integrated Assurance Committee?
Yeah, I think you're right, Christy. I mean, subject to the work that Jean has alluded to, progressing at that sort of time frame, yeah, we can absolutely accommodate that in May, and perhaps I can link with Jean and just confirm that time frame is realistic, and then link back in with the chairs of the committee just to confirm that on the agenda.
Yeah. Does that sound reasonable for people? As clearly there's been some suggestions around that. I mean, we'll confirm that, as Richard has suggested, with discussions outside of the meeting. But as there was support for it, that seems like an appropriate way forward. I'll bring Julie in, and then Chris for a comment as well. Julie?
Thanks, Krishni. It was really linked to what you've just been talking about, because Jean referred to a piece of work that we're commissioning around a quality review and safety review around the issues we've had around data. It won't be ready to report in May, but I think it needs to go in through, I was going to suggest a Quality and Safety Committee. I've forgotten its changed names, because it is about quality, and that's the angle we are taking around patient safety. So I just wanted to put that on the table as well.
Okay, thank you, Julie. So I think we'll let Richard and Chris work through the best route to get us there and the best time for it to land. But I think the principle of doing a deep dive on it is what we've agreed, and I think it'd be helpful to take it forward on that basis. Richard, Chris has put his hand down, but I'll bring you in at the end, Chris, if you need to comment. Richard?
Thanks, Christy. I just wanted to cover risk B8, the finance risk around delivering value and use of our resources. We had increased the risk to a 20 in this report when we reviewed it through the strategic exec board. I think, as the board's aware, we've been pursuing a whole range of mitigations to deliver our share of the system agreed deficit for 22-23. We're not quite at the end of the year. We're kind of on the verges of coming up to the end of the financial year, but we are confident that we will deliver our share of the plan. We have made a lot of progress on the risk mitigations that we identified. The concern when we increased the risk rating was the timing of those getting concluded by the end of the financial year, but I'm pleased to report that we have made solid progress on a range of those. So we'll probably look to retire this risk sort of at the end of the year and review how we're going to take the risk into the next financial year. Thank you.
Thank you, Richard. I did have just a question sort of linked to financial performance around the system risk element. I was sort of interested to get people's views, really, Richard in particular, maybe Angela. Particularly if you look at the ICB current risk score and you compare that to the two provider risk scores, there's quite a significant difference in score. And I'm just kind of questioning in my mind whether that feels appropriate and why there is a significant difference in score, bearing in mind that the ICBs, I know the ICB is not just about the providers, but it is obviously a big significant element. The ICB's own overall risk around finance is based on provider financial performance. So it's an observation. I don't know if anyone can answer it, but it just feels like something we ought to explore collectively. I don't know if Richard or Angela has a thought on that.
Actually, I mean, I think it's a valid comment, isn't it, really, in terms of probably different approaches to risk appetite and different kind of history and journeys to where we are now. I think it would be sensible, and we have talked certainly to the Chief Finance Officers group around getting more consistency around how we are counting things like efficiency and measuring risk. And I think, yeah, I think we've seen some further evidence of differences there. So I think it's a good challenge and something that we should look to take back into the system and through their committees.
Thanks, Richard. Angela?
Yeah, totally agree with Richard. I think it's about consistency and the maturity of ICB and how it, if you like, emerges its position in the context you've described, Christian. So I think that's the work that needs to be done. I think there's more work to be done, as you'll recognise, in the ICB about risk generally.
Yeah.
As well.
Okay. Thank you. I just thought it was important to note in the context of the system risk position that was presented. And just on the BAF point, clearly, I think the BAF is the more recognised approach, isn't it, within the wider NHS? And we've always been confident that our ORR has been the approach that we've wanted to adapt, and it worked for us. So I think just understanding, perhaps exploring a little bit more of that thinking might be helpful at the workshop that follows, just to recognise the need for that change. But I think, as ever with all of these things, it's always right to keep these things under review and realign and address changes as address need for change as appropriate. So, Chris, any final comments from you before we close on that item?
Yeah, so I think echo what you've just said, Christian. I think we've always got to remember that continuing to review things shows, I think, how we effectively manage risk. And I think the point on the joint committee is a good one, subject to, as Richard says, liaising with Jean. And that's almost emerged from the work we've done, that's the very thing we're looking for it to do, where we get something like this come up that probably does need a real deep dive. We can't, probably it would take up too much time in a committee maybe that didn't have the space for the deep dive. So that's where the integrated risk committee, as you say, integrated assurance committee could really, we see it come to the fore. So I think it's interesting it playing out in the board. That's quite positive.
Yeah, great. Thank you. Is everyone content with where we've got to then on that discussion and the key points we've agreed to take forward around the BAF and that particular risk, and also I think noting the point around the risk appetite around financial performance and the consistency in the scores with the system. Okay, we move on then. Oh, before we move on, actually, just give Jean an opportunity just to, under the risk heading, pick up any COVID-19 or system-wide winter planning updates, Jean?
Thank you, Christian. So obviously the board will be aware that we have been in the throes of winter since the last board meeting, and therefore there has been a number of challenges across the system in terms of pressures from an urgent care point of view, both actually from mental health, that remains really high in terms of the pressures on the inpatient services and the crisis and community services, as well as a high number of attendances into our colleagues in the acute A&Es over this period. There has been a number of industrial action, particularly the junior doctor strike, which took place, that did have a detrimental impact, and we didn't actually see any change in terms of the public's behaviour during that period of time, which is different to where we've experienced had industrial action before. So interesting, and I think it's something that our colleagues in NHS England have reflected on in terms of their communication levels out to the public. We are obviously expecting more strikes from junior doctors later this or next month, which again we will monitor and manage very carefully through our strike action group. I think in terms of winter planning, Krishni, we have been having a significant number of conversations in terms of the financial envelope for urgent care into the next financial year. Those conversations are still ongoing, and we are, as a group of COOs and DASs, measuring the potential impact of any decisions that are made, so we can make sure that colleagues who are making those decisions make them in a fully informed way. So challenges continue. The team remain absolutely amazing in terms of the work that they do every day, and I don't think Anne or I or anybody else at the exec board could thank them enough, really. Thank you.
Thank you, Jean. Anything that people want to clarify from anything Jean has said? Okay. I mean, I think just recognising that I think the next junior doctor strike is proposed as 4 days, isn't it, Jean? So I mean, we need to recognise that, you know, clearly the challenge for all systems, I think, around the 2 days originally that we've just recently had to a 4-day strike is a significant risk. But I think the important thing here, Jean's point about recognising, you know, the pressures that clearly are across the system and the work that we know all the teams are doing, trying to continue to maintain service levels at the level that we would expect. You know, we on behalf of the board, I think we need to recognise that and thank everybody for their continued efforts, because it is a considerable strain, I'm sure. Banu.
Just to come back a bit on the junior doctor strike. We have regular meetings with the BMA, who oversee the different trusts' response to the strikes, and they are pleased with kind of how the trust is pulling together in terms of strike action group, supporting juniors, kind of looking at what the consultants need, and we have in some ways learned from the first time and kind of had a more streamlined approach to get things in our place. But again, as Jean was saying, that there is definitive effect on the ground in terms of the response. So there's something that we will be keeping a close eye on in terms of the assurance to the board. Thank you.
Thank you, Banu. Thank you. That's really helpful. Okay, so we note that update and Banu's additional comments, and you know, clearly, as I said, recognise the enormous efforts of our staff in maintaining service levels in this challenging period. We now move on to the assurance report from the joint meetings of the Performance Committee and Quality and Safety Committee. Potentially the final report of the current version of this committee, so paper E. And let me just check, was it Julia who chaired this? Julia, anything you want to comment on with regard to the report?
Thanks, Krishni. Just to say to everybody, this dovetails actually back to the previous conversation we've just had around the organisational risk register. So you'll see that the commentary absolutely reflects the three sort of main areas around the exec workshop, which we really welcomed, the development of the system risks and the maturity of those, and this was the only item actually in the committee this time. We didn't actually undertake a deep dive. And just to say that paper T, I think a little bit later on, talks about the future format of this committee going forward, which we all supported. So nothing else to say or to add unless anybody's got any comments.
Okay, thank you, Julia. Any questions or comments relating to that item, that paper in particular? Okay, nothing. So thank you very much, Julia. We're just asked to really note the assurance provided and the work that the committee had undertaken as part of that meeting. We move on then to our strategy section. Before we go into the formal reports, we've just got an opportunity for any emerging environmental issues to be reported to the board. So Angela, anything you wanted to highlight under that?
Just a couple of things in relation to University Hospitals Northamptonshire. People may have seen that Simon Weldon, Chief Executive, is moving to South East Coastal Ambulance Trust following his period of tenure at the hospital. So we wish Simon well with that. We also see that there will be some movement in the North Unitary Council with Rob Bridge as Chief Executive, again, securing a role in Cambridge and Peterborough. So again, we wish Rob well, and I know those changes will mean that obviously changes at a senior level within the ICB and partner organisations. We've also this week concluded, yesterday in fact, our work with St Andrews organisation. So just to remind everybody, we've been in a programme, a pioneering programme of quality improvement supporting St Andrews on their Northamptonshire element of their national work, and that was following their CQC ratings. Julie's been leading as the improvement director, and we've had a buddy arrangement as an organisation operating with an East Midlands Alliance approach to that. I was really pleased to chair the meeting yesterday and conclude the work. That said, there's still work to do, and St Andrews understands that, and we have examined that against a set of exit criteria, or rather Julie has, which the group received yesterday. So there is work still to do, but there's real improvement. And I think the other thing to say is that comms have also captured for us a video of the work streams across the East Midlands Alliance, which again we can share with board members just to give a sense of the work that has gone on. And with NHSE, they're really pleased to hear that they do see this work as very valuable and adaptable to other areas of quality improvement. So really pleased, and just say thank you to Julie for all the work that she's led in this arena, which has been fantastic. Thank you.
Thank you, Angela. Yes, really huge thank you to Julie. It has been, I think, you know, it's potentially I was going to use the word game changer in the way that you know, it's for others to decide, but I think in terms of a model for support, I mean, obviously we need to recognise it's never been done before that NHS organisations collectively and an NHS trust buddied an independent provider, albeit a charity. So that's a first. But I think also the fact that it was a collaborative, albeit we were the lead trust in terms of buddying. I think having a collaborative approach to that is also really a really great example of collaboration in practice. So I think thanks need to go to the East Midlands Alliance as well for supporting that. Yeah, it was excellent to be there yesterday and sort of feel the change, if I can say that. I know, you know, what Julie presented was evidence of the sort of work that had been done, and Angela rightly highlighted there were other things to be done, but it was really positive to feel the change and the collaborative relationships that have been built through the work that had been done, which in itself is an outcome that we should all value, I think. So just wanted to say that and recognise, I think, a very important development for all of us. Julia?
Thanks, Chrissy. Just to echo all of that, I was part of the overall steering group. But for me, that one of the most important things that I've seen over the last sort of year has been the reciprocal learning for an HFT as being part of the process, and that's been incredible. And our teams have got so much out of it from the new sort of relationships. And I know that we'll be taking a lot of things forward. So again, thanks to Julie and to everybody for being part of it. But actually, for us as an organisation, I know we've got such a lot out of it, and it's been really quite a privilege to sort of watch from afar and be part of. So thank you.
Thank you, Julia. Angela, just going back to the acute group, is there an official position for the board to note on the arrangements with Simon stepping out away from the role and going off to another trust? Is that is there an official position at the moment? Okay. Thank you. Right, so we move on then to the my chair's report, which is paper F, and I just really wanted to highlight, I take the report as read, just wanted to highlight a couple of things to bring to the board's attention. Particularly, I think important to say that we are in the process of trying to secure a deputy lead governor for the Council of Governors. And we launched a process after the last council meeting for that. That was very much supported by Chris Davison, our lead governor, who, as you know, is stepping down. And we felt the ideal opportunity was for us to appoint a deputy who would undertake the lead governor role when Chris stepped down, and then elect a new lead governor once we've got our full our new members of council elected and inducted and settled into their roles. So that's the plan, and we're hoping that will come to fruition. But I do want to recognise very clearly the significant contribution that the governors who are named in the report have made. I can think particularly, I think we've done a number of recruitment campaigns during these last few years, and a number of those governors have made a really significant contribution by helping us to recruit our board members, not least Julia and Judith, Saqib and Robin, who are present with us today, and they've played such an important role in that, amongst many other things. So I really want to thank them all. Too many to list, but their names are noted in the report. We have been through an election process, and the report on that is there. So we are expecting to be, I think, bar a couple of vacancies, we are expecting to fill the complement of posts that went out to election. So we look forward to welcoming our new governors. I also wanted to recognise that we will have officially already onboarded Joanne Lancaster as our new Associate NED, and we also have Tim Harrison starting with us officially on the 3rd of April, I think is his actual start date. One other brief thing just to note, really, that we've had this proposal from the chair of the Integrated Care Board for NED attendance at several committees of the Integrated Care Board, and we're working through that at the moment. Our NEDs have been very supportive of the opportunity to engage, so we're looking to go back with a suggestion or names to add to those committees so that we can really trial that and see how that works, so we can take a collective view on the value that that's adding. And then finally, I just really wanted to ask board members if they would make the effort to support the feedback process for non-executives and the chair, because you will be receiving, if you haven't, I think you probably will be receiving, it may not have happened yet, but the feedback process will launch for you to provide feedback to colleagues as part of the appraisal process that we have. So we'd be very grateful if everyone could play their part in providing feedback. So that's everything that I wanted to cover. Oh, actually, I mustn't forget a little thing just to mention, really, from yesterday. I had the privilege of celebrating with the Recovery College yesterday, which is one of the fantastic services that we provide. Anne was present as well, as were other members of staff. Angela was going to be present but wasn't able to be there. But it was such a lovely event, really a fantastic celebration of a brilliant service. For those who are not familiar, I mean, basically it's it's providing, it's really learning opportunities for service users and staff who can benefit from attending the training. The training is quality assured by educational professionals, and the really fantastic part of it is all of it is co-produced, as you would expect from the organisation, and actually the range of courses now on offer, starting from 4, I think, in 2017 to around 50 now, is really quite something. And I think the biggest thing, the most heartwarming thing, was hearing about peer trainers, people who've experienced, in some cases, significant health issues, actually being involved in the Recovery College and being peer trainers, and how that has helped them in their own recovery. It's an incredibly powerful story. They sent me the slides that they presented, so I'll circulate those round. And I would just encourage particularly non-executive colleagues to maybe attend some of the courses, actually. I think Melanie did that a while ago and found it incredibly useful. So it was fantastic. I just wanted to say that. I did tell them that I would mention it today, and I think they were quite pleased to hear that, because it was a very important occasion. So thank you very much. So if there are no questions for me on any of that, I will hand over to Angela for her Chief Exec report.
Thank you, Krishna. I'm really pleased you mentioned the Recovery College. I was really sorry to miss it because of the COVID, but it also just reminded me that it links actually with SARC, because it's a very person-centred service, and it's of no surprise, but probably is not known by everybody, that Sarah Dunn, who leads that service, actually used to lead SARC. At the very beginning, when we started SARC, she was that manager, and she was, before that, a PA for me. So that also tells you some of our career journeys in the organisation as well, in terms of how people go through the organisation. And I know the passion that she's had has gone into the Recovery College from SARC. Really oh, has that gone off?
Yeah, it's just sometimes I think the mute button seems to come on. Yes.
So did you get all that? Sorry.
I think we might have missed the tiny bit at the end, but I think we got the gist of what you were saying.
Okay, thank you. So just a couple of things that I wanted to mention or draw out of the report that I think important to highlight. So it was really great to see the National Porter Awards being won by our colleagues Danny and Gemma, and I think that, you know, if you've not seen that, please have a look at it. It was fantastic to see them being shortlisted. It was even better to see that they had won, and to see that role being celebrated in the way that it is across our organisation, but also across the country. So really great. I'm very pleased that we have been one of the sites selected across the country around innovation for collaboration. I think this is really important, and obviously David Williams, as our Director of Strategy, leads this, but this is one where we have submitted as part of our group across NHFT and LPT. And clearly we have also taken significant steps to be collaborative in local system across the East Midlands and across the group, and then obviously St Andrews I've already mentioned this morning. So I think it was really great that that's been recognised, and I think it will give us a platform to, if you like, pioneer again, which is clearly what's needed in this space nationally, but also to bring our partners with us. And David was able to come to the Chief Execs meeting yesterday to describe it. Toby joined a national forum this week as well to hear more about it, and I think action and learning sets coming out of that across the system will be really powerful. And I know that Anna, joining in that conversation from the West Northants yesterday, was really keen that local authorities play a part in that. So I think really important work, and one in which we will continue to develop in partnership, which is clearly part of our strategic direction as well. Chris, did you want to come in on that?
No, it's not another point.
No,
Angela, when you finish,
okay,
when
thank
you
you.
finish.
Yeah, okay. And then just mentioning volunteers, and you know, we talk about volunteers often, but the fact they've achieved their investing in volunteers accreditation again is a real testament, and we've seen a lot of development in this space over this period and during COVID, in fact. So I want to just say thank you to all of our volunteers, but also to those who are leading it. I did take part in that accreditation process myself, and I did receive very positive feedback on the team and the way in which we're investing in volunteers too. But I also spent some time with our chaplaincy service volunteers recently as a celebration of the work they've done over many, many years in this organisation, and much before many of us in it. And it was really great to get that celebration with them. But I think it's also important to note and receive their feedback that during COVID, they found that really hard to not be involved in the same way. And I think that was a really difficult period for them. And we did discuss that and understand that that was challenging because, of course, they are such an integral part of what we do, but it's also mutually beneficial for them as individuals to be volunteering in that way. Again, just to highlight to people, if you don't know, that it's World Autism Acceptance Week this week, really important to flag that. Please have a look at it. Please think about how we are contributing to that acceptance, whether that's through access to services, whether that's about profiling through employment, whether it's about the inclusion and diversity, the staff networks, all of the things that we know contribute to this. I think if we could all go away and think about one way in which we're doing that, that would be really helpful. And then the final bit that I wanted to say is obviously a general thank you to everybody in the organisation. I think you've said it already, Krishni, around the pressures that are on people. The thank you that we constantly say, but we will continue to say because they are going above and beyond. We talk about the clinical services. I know Jean's mentioned the operational pressures, but this is pressure across all staff, whether they're clinical, corporate services, volunteers, everybody's under pressure of a type. And we do recognise the work that everybody's doing. So it's important that we keep saying thank yous because thank yous do mean a lot to people. And my final note is to say a big thank you and a good luck to Jean, because Jean is going off on secondment to our group partner, LPT, which is good for me because I will still be working with Jean as the Deputy Chief Exec and Managing Director over there. And this is a great opportunity, I think, that we want to support in development. But I also want to say thank you to Jean as she departs from NHFT for that period of time, for all the work that she's done within NHFT, but also in the system. And I think she knows that, we know that, but it's important to say it, Krishni, that we wish her well in that development. We know that we're going to stay close because within the group, but obviously that is an important step that we would want to support Jean on. And part of that is obviously to support Anne as well in her development opportunity that she's going to take now in the chief operating role. So I think a really great example of talent across the organisation, across the group, and we wish them both well in that. Thank you.
Thank you very much, Angela, and absolutely support, what you said. I think on behalf of the board, Jean, congratulations. We're going to miss you, but you're not going to be far away. So actually, in a sense, it's, just another opportunity to kind of continue working together in different ways, and we look forward also to working with Anne in her new capacity. So good news all round for everybody, and something we should be proud of, that people are able to make those steps, and that we've been able to support that. So thank you so much. Chris.
Yeah, I just wanted to draw something out, Krishni, that I know you're aware of on the RES report. Just to alert the board to something where some information wasn't correctly reported, but also some positive news as well. The board may or may not remember that we've been very challenged around the ratio of BAME staff going into the disciplinary processes, and we actually reported to the board last year that that had gone up to over 4, and if we included the medical staff, it was actually up over to 8. This was because we had such small numbers of disciplinary cases, sort of less, around 10, and we did validate that all the formal cases were, they were unavoidable, they needed to go through. In a report to the regional people board, however, we had a bank staff included in the figures, which meant that it actually went up to 11. So that was a cause for concern. In response to it, however, we had introduced at the beginning of the year a decision-making group involving directors, cultural ambassadors and the HR team, and we've actively reviewed all the cases. And actually, it's likely that as we come into this year, we will have seen that figure reduced dramatically down to sort of circa 2. Still not where we want to be, but I think clear that we are taking measures to address it. We've also put processes in place to review disciplinary cases within the HR team. And again, that will lead us to be able to better manage it. So I just wanted to make sure the board were aware of that in case people saw information, it's right that we share it.
Thank you very much, Chris. Yes, helpful to comment on that, just because there was a slight difference in the figure reported to the Regional People Board. But it is interesting because that figure anyway relates back to, and if you go through to the link in Angela's report, which actually talks about the latest RES data, it is actually data from March 22. So it's there's quite a big lag, isn't there, on this sort of national analysis and reporting, and actually the positive thing from our point of view is that we've already been working, as reported to the board, and as Chris has commented, we've already been working on how we address that. So we have fed back. I know David has been actively talking to the regional colleagues about that figure and the difference. So I think that's been resolved, but we'll hear more in due course about the steps we're taking on our RES data. I think that's due back later in the year, isn't it, Chris? Anyway,
yeah, the next couple of months, and obviously we've got some data in the staff survey we can talk about a bit later.
Yeah, so we look forward to seeing a proper analysis of that, but just thought it was important that the board were aware that a different figure, or the figure that the regional team had, was different to the one that we'd reported to the board previously. So thank you very much. Are there any other comments or questions for Angela before we move on? No? Okay, thank you. And we move on then to paper H, which is the annual plan. So over to Dave. David?
Thanks, Krishni. So just to remind colleagues, we had guidance published in December detailing the things we needed to deliver as part of an operational plan for the NHS in the coming year 23-24. We, in previous years, have used that as an opportunity to bring together our DigBQ plans and have one overarching plan within DigBQ, which captures the operational plan for the NHS, the things we're mandated and told to do in guidance, and then the annual plan for us as a trust, which is both an inward-facing and an outward-facing document detailing our ambitions for the year and how they link with the overall NHS ambitions. So in line with the NHS guidance, the focus of the plan this year is on recovering core services and productivity, progressing key ambitions in line with the long-term plan, which we're well down the track in terms of the long-term plan and its expectations, and then an expectation to continue transforming and continuously improving for the future, which is part of the overall framework. The plan, as outlined, is in 3 sections. We've got an introduction, then we get into our operation plans, and then we get into our enablers, so the things that help us deliver those services to patients. And this is all about patients and our teams working together to deliver quality outcomes. So I'll take it as a document that's read. I'll defer to David in terms of some of the DigBQ bits, if he wants to come in on those, and then happy to take any questions.
Thank you. Thanks, Dave. Oh, sorry, go on.
No, go for it, Dave.
So just a brief bit to add to provide some context for particularly non-exec directors, was to say that the areas of the plan, under the section on each page, which is we will focus on, are the ones that then we want to draw out through transformation committee that will set out the objectives of the things that we want to work through each quarter, and we'll bring those back in a kind of update format to show you each of the different things where the progress is being made. So then you've got our proposal of what we will achieve during the year, and then a quarterly update of the things we are focusing on by teams and the delivery of those.
Thank you, David. I saw that your hand went up, so did you want to come in first?
Thanks. Thank you. Sorry, I took my hand down just to listen to David. Thank you very much. David, you partially answered my question. Whilst I was reading the document, which is really useful in bringing together the national, the ICB, and also our local, if you like, our trust picture. But what struck me was that clearly, in order to measure that we've we're reaching our strategy and meeting our strategic aims through this document, through this plan, there will need to be deliverables, quite hard deliverables, and KPIs, if I mention those dirty words. And I was just wondering where we would, as from a non-executive point of view, where I would go to see those and how they'll be tracked going forward.
Fine. If I was to predict something, Melanie, were you about to ask a similar question? Do they link together, or
Very astute of you, David. Well, I was first of all, I was going to compliment you on, I think, a fantastic and professionally produced annual plan document, very easy to read, and a great sort of published sort of overview and strategy. But yes, I was going to sort of just following up on the comment you made about how that was going to be tracked at a more granular level. I was just actually going to ask you when we were going to see the first one of those, and then how that will develop. I know we've received previous reports and asked for more detail, so just wondering how you develop the template.
So what we've said we'll do is, take out the bits we'd focus on, take those into transformation committee, where they then get refined into the deliverables of the work we're going through. Transformation committee meets on a monthly basis, so we'll track through what's happening there, with a quarterly summary coming via strategic exec board and into performance committee. And so the next update through would be after Q1 gets complete, and I think from a board cycle perspective, that will give us a July update, although I was just suddenly thinking I think performance committee might be June. So we'll just have a look through, but that's the aim, is to come in once a quarter with an update of progress.
Thank you. Does that answer to your satisfaction, Judith and Melanie, those questions? I think we do have a cycle, don't we, Richard, on our forward plan for reporting back on this. So we'll need to just, kind of go through that loop. But I think David has described the process for getting there. Is that okay for everybody?
Thank you. Yes, obviously proof of the pudding. This is on the 6th of July, but yes, thank you very much.
Thank you, Judith. I just wanted to echo Melanie's comment. Actually, I found it a really uplifting plan. I found it a very easy read, and I think that's really important, because it just made, it sort of felt like it made sense and resonated. So in that sense, notwithstanding the comments about measuring the impact and deliverability and all of those things, which are absolutely right, I think in terms of communicating what we're about, what we're trying to do, that I felt it was a really good document. A couple of reflections, really. I think it was really good to mention the scheme for, I can't remember now what it was called, but the pioneer, being a pioneer for provider collaboration. I don't think it uses those words, but you know what I mean. That scheme,
Innovator.
The innovator, that's it. I keep thinking pioneer, but I think that because we have pioneered some things. So I think that, I thought it was really good that we reflected that was an opportunity for us, I think, within the plan. I just really wanted to emphasize a couple of points. One was just about championing out of hospital care, which is highlighted there. And I think for me, the benefits of, I'm assuming that's not just ICANN, but obviously the benefits of ICANN, because I do think we've talked about that before, that it's really important that we have a collective understanding of what the impact of the work that we're doing. And certainly I think Ned's reflected to me that in one of our sessions with the ICB, it didn't feel like that was well understood. So I think it's really important that we collectively talk with colleagues around the system about the work that we're doing with ICANN and how it's benefiting all parts of the system. The other thing was just really about transitions from children and young people's care to adult, and I know that that's always, there's always a risk when we think about children and young people and adults as separate sort of things, but I think that transition does feel really important for us to recognise somewhere. So that was just a couple of observations, but I really welcomed the plan and thought it was a good document. Robin.
Yeah, again, totally support everything that's said. It's beautifully produced, beautifully written, very clear. But how are we going to communicate it? How do you then communicate it onwards to the wider population beyond the trust? Is there a role for the governors in helping to communicate all this to other people? So it's just a question about the communication and onward channeling of this, so that people can see what we're doing, all this excellent work.
Yeah, really good point, Robin. David, do you want to come back on that and
Yeah,
anything
that's
else?
perfect, because it also links into one of the bits I wanted to talk through. So the bit that I didn't say at the beginning was actually the governor session on helping us shape and provide the feedback had been really, really helpful. And then sitting down with Dave, with Dion's team and colleagues to say, right, how do we present this, had been something that we'd worked really hard on. So the aim today was to share it with us. I mean, it now, through its nature, becomes a public document. And so actually we can report and update on this progress. And Robin, you're absolutely right. Something that we can share with governors, people can start talking about, and we can share with the public that these are our focuses for the coming year and the work that we want to do. So yeah, I agree entirely, and we'll keep coming back to it in public meetings to update on progress.
Thank you very much, David. Dion, did you want to add anything?
Yeah, I think that David's essentially covered it, but I think it's important to note that we did carefully work on breaking it down into the we're focused on, so that we can work together in sharing that messaging, and also so that we can do that on the quarterly cycle basis, and we can continue to ensure that the ethos of what we're trying to do is coming across. So it's really positive to hear that that's been noted, and that is how it's been felt and received.
Thank you, Dion. Dave, any final comment from you before we close?
Just to thank, thanks, Chrissy, just to thank colleagues and the teams that came together to pull it together during everything else that was going on. And we were quite clear as a group that we wanted to be demonstrative about the so what. So if we're going to say we're going to do something, then what does that mean? And we've tried to kind of encapsulate that in the document, and we'll be doing more of that with the engagement that happens over the course of the year as further conversations develop. So just warm thanks to everyone, real teamwork across the organisation, and a great output.
Thank you, Dave, and very much acknowledge that, I think. And we're just asked to endorse the plan and take it forward in terms of review and reporting back in the way that's been described. Obviously, continue to receive the quarterly reports, and I think certainly we'll take the action to make sure. I think governors would, Richard, have received this. The documents already, wouldn't they, as part of the board pack, and we can report to them that this was approved following their input to it as well. And as part of our reporting, we can highlight to them progress against it. Thank you very much. Great work, everybody. So thanks again. Right, we have some people items. We are a little bit behind, but I think I might take a view that rather than go into that section, if it's all right with you, Chris, we'll take a short break now, a short comfort break, and then reconvene at 11:10, if that's okay, and then we can get on with the people section where we've got a couple of really important papers. Chris, does that work in terms of timing for you and for Gabby? Is that okay? Great. Okay, can we reconvene then at 11:10, please? Right, welcome back, everybody. So we're going to make a start on our people section of our agenda. And the first paper I, is our annual gender pay gap reporting paper. So it's over to Chris.
Thank you, Krishni. This report covers the information for 2022 compared to 2020 and 21. Our gender pay gap calculate is the average hourly earnings for males compared to females, and it's remained fairly consistent for us around 17%, though the median pay gap has fallen from 8 to 6%, and it does compare, it does relate to the sort of 15% that's the across the country, the overall figure that we get. I think the other key things to note are that Males within the trust are disproportionately represented in the higher quartiles. And on the bonus pay gap, we have narrowed that gap quite substantially in the figures that we've now seen. They're the main highlights. I think what's quite important is to note the final page, which are the key elements, because we continue to focus on this within our people plan, and we continue to focus on elements that will support narrowing that gap. And we have got a good response from staff in terms of we work flexibly, which is obviously a key element to support people. We ran really successfully this year an Admin Professionals Day, and having staff represented in the more less well-paid elements. So there was a lot of female members of staff attending that. And it's a real focus that we start to build careers for staff at the lower grades to develop within the trust, and that clearly will support us. We also continue to run the career development workshops, which are very focused on supporting staff to help them grow within the trust, and we get really positive feedback from that. So that's a sense of the work that we continue to do to ensure that we can narrow this gap and take positive action. And really the focus moving forward, as we've shared with the trust, will be the people plan, which will continue to encompass these areas of work and to take them forward. So happy to take any questions, Krishni.
Thank you, Chris. Any comments or questions from colleagues? Okay. Doesn't look like there are. I mean, Chris, I just wanted to observe really the point number 7 on the list of initiatives, because that felt quite important, really, supporting female medical staff, I think, around the Clinical Excellence Awards. Is that something we're going to continue to do? Was my only sort of specific question on the paper, because it does feel like an important area for us to try and support the development of our female medical staff in terms of progression to consultant, but also Clinical Excellence Awards. And the only other question is, I think there is a requirement for us to do this, but currently there's no requirement, as I understand it, for us to do a race pay gap. Although some organisations do that. So just wondered whether you've got any thoughts on that, Chris, on both of those points, if you wouldn't mind.
Yes, certainly supporting the female staff. We've increased our medical staffing support quite dramatically. So that is something we will be working on. And we've got Becky Salisbury in the deputy director role there, so something we can pick up. Yes, we can look at that race pay gap. We are considering that. I think it's probably worth to note that it probably doesn't represent in the same way. So our BAME staff are disproportionately underrepresented in the lower bandings in the trust. BAME staff are really represented mostly in bands 5 and above. And clearly we do have a high proportion of BAME staff in our highest paid group in the consultants. So I would think that it's not quite represented in the same way, but I think it is useful to look at, and we do look as part of the overall requirement and expectations of where people are placed in the bandings, which we're ahead of. But yes, I think it would be informative to look at that, and I'm working with David on that, Krishni. But as I say, I think it probably is a different picture to the one we have here.
Yeah. And it would be an interesting picture, wouldn't it? Because I think, it's also if there is a positive story to tell on that, but I think it's important equally to share that as well.
Yeah, I was just going to say, Krishni, I think clearly also on our res figures, we are attracting more reach or BAME staff into the trust. So I think we have a reputation as an employer. Our big focus though is on what their experience, what they feel is critical. And particularly I've talked to Angela recently about what more work can we do about the recruitment and the ratios there. But I think if we are known as a good employer in terms of diversity and we give the career progression, to me, certainly my feeling is that's where we want to be as an organisation.
Yeah. Well, yeah, absolutely support that. Thank you. Scott.
Thank you, Krishni. Sorry. So, Chris, thank you for the report. Right, I want to acknowledge the progress that's there, but I would say, if I'm honest, I think that the progress is slow or minimal. I wanted to reflect back as well. I want to make sure I've taken it on board properly, because when you were talking, one of the focus areas that you brought forward was a very merit-worthy bit of activity, but it seemed to be the inference was that the route for better pay for female staff was through development and career progress, rather than, as the report's title would infer, genuine gender pay gap being closed. Can you come back on that one, please?
Well, yeah, I suppose all our pay rates are the same. So unlike in years way gone back with differential pay, so all the pay is the same. So it will relate very much to where people are placed within the bandings. So having higher proportions of female staff in higher bandings is likely to balance that out, I think.
That doesn't seem to address a point about equal pay for equal work. Really, that's
no,
the point.
Well, equal pay for equal work is absolutely sorted, because it's Agenda for Change is nationally recognised as having a job evaluation system which recognises the equal pay for work of equal value. So I think that it is very much more a kind of a career development issue than there isn't a. We would be very worried if we were paying people differentially based on gender for the work they do.
Yeah, I think that the report does draw that out, that this isn't really an equal pay issue, but it is about making sure that women are represented at the higher levels in the organisation. Certainly access to bonus is important, isn't it? Which is why things like clinical excellence awards, I mean, clearly the vast majority of grades are, the salaries are, well, there's a job evaluation process in place, isn't there, Chris? And salaries are defined by Agenda for Change. So by definition, there shouldn't be, I mean, that's not to say there aren't. I can't categorically, wouldn't be able to put my hand on my heart and say that, but there shouldn't be, because of the processes that are already set within the NHS, an equal pay issue. But what there is, I think, is we have a huge proportion of female staff, and actually they're not sufficiently represented probably at senior levels in terms of earnings because of progression opportunities. I think that's what the report is trying to highlight. Am I right in saying that? So is everyone comfortable with that kind of understanding of it? Because I think it's important we're clear about what the report is telling us. Scott, do you want to clarify anything? And we'll bring Chris back in.
So, Christine, thank you for that, and thank you, Chris. Right, clearly I've read the report. Right, part of the NED role is, of course, to challenge, because despite all of that, the report tells us that the gaps remain. So I thank you for that. Right, I get the focus areas. I wanted to challenge a bit further. I think I'm satisfied with the responses that I've received. So thank you.
Thank you, Scott. Chris, did you?
Can I just come back? Yeah, I mean, I accept that. I mean, I think this is, as with a couple of other things that we talk about, it is a wicked issue, a complex issue, but it does probably draw out. I don't know if there was the national report about the kind of barriers that still put in the way of female workers, and some of the comments that some of the FTSE 100 male board members made, which were appalling. But there is still that glass ceiling. I think it's still a reality in a number of areas, and that's what we need to continue to push to break and make sure it isn't in our organisation.
Thank you, Chris. Saqib?
Yeah, I was just going to ask, obviously you'll have this data grade by grade. So do you see a similar 17% difference grade by grade, which based on what you're telling us, that shouldn't be the case? But what I'm aware of from lots of different industries that I've worked in or heard about, where you have grades, sometimes a male worker will come in on a point on the spine at a higher level than somebody else. So if there's a range, so it might be a level 5, 6, 7, whatever, but if the range is, say, 5K, they'll come in at the top of that range, whereas a female worker historically might not have asked to come in at a higher point has come in at a lower point, and so that's already leading to that gender difference. So I hear that the same grade, so if you're level 1, grade 1, you will be paid the same. But if somebody is coming in at level 5, you know, at a higher point, then that's going to lead to the discrepancy as well.
No, I would say that isn't the case. Agenda for Change is, I mean, that's probably an issue, but it's pretty rigid. So it's based on experience, which would apply across the genders. So it's highly unlikely that you'd see that a male worker would come in a higher pay point than a female worker. It would be based on the levels of experience that they've got. So it would be consistent, and that's also part of the equal pay for work of equal value type measure, which Agenda for Change is. It's got many faults, but that's probably not one of them. It's quite strong on that.
So grade by grade, the range is a lot narrower than the 17%. Is that what you're saying?
No, I'm answering your point that a female worker wouldn't come in on a lower band than a male worker.
Okay.
I mean, clearly the bands may not be this, because I mean, we're saying that there's a higher proportion of males in the higher grades, aren't we, within the report? I mean, we could do an analysis by grade as well.
I mean, I think that would help for me, at least, give me peace of mind, that because, you know, if it's gone from 18 to 17 to 17 or whatever, and this is 3 years on, we need to understand what the real drivers are. And I think just by having more development, I don't think that will close the gap based on our current trend, or, you know, getting people into different, you know, going into higher grades or lower grades or whatever, you know. We're always going to have, for example, on to Krishna's point about like BAME, there will be in psychiatry, there will potentially be more BAME consultants for a period of time. So that's not going to address that. So it's trying to see, are there other drivers that we're not aware of currently?
Yeah, well, I think I mean, obviously we can do more analysis and see what we can do about that for sure. But I do think it will be around the career progression, but we can do that, yeah.
Thank you, Chris. So how realistic, I mean, you know, what's involved in doing that, and how long will that take, and, you know, just understand. Do you want to think about that, Chris, as to what more we can do on this?
Yeah, I mean, it's levels of detail, isn't it? I mean, I think we can, I mean, I don't think it'd be overly difficult to take the bands 1 to 9 and show what the proportion of males and females are in each band. I don't think that would be an overly complicated thing for us to do
Okay.
at all.
Okay, so if you're happy to do that, we'll leave that with you to come back to us with an update on that. Would that be, and maybe we could take that to, I'm just trying to think in terms of, do we want to bring that back to the board? Or perhaps we can pick that up at NRC, Chris, because I think we have also talked about these issues within NRC, haven't we? Just wondering.
I think it'd be more sensible to take it to the joint committee, because that's going to be tasked with looking at workforce, isn't it? So.
Okay, yeah, good point. Okay, so if we can agree, again, Richard, if we can agree an appropriate timescale for that, and then pick that up as a sort of further analysis on that, I think that would be helpful. Melanie.
Thank you. I realise I might just be building on the last point, but I think my consideration of this paper, whilst I have no doubt that this is a formula set of metrics that we are required to produce and report, I think the discussion has demonstrated that it doesn't in any way talk about the actual issue, which is the earnings gap, not really the pay gap. The pay is Agenda for Change. It's entirely it's entirely equal, or meant to be. It's the earnings and the rate that you progress through the bandings that are the key issue. So my point was simply going to be that I think we need to see a different set of metrics to actually understand the issue. These metrics aren't actually in any way informative to give us assurance. So I think we've discussed the metrics that we maybe need to see, and it is the rate of progression through the bands to see if women are progressing at a slower rate than men. I don't think it's enough to just to see a static picture of how many in each band. I think it's how is the banding progression. And it used to be that you used to be uplifted every year whether you liked it or not. I don't know if that's changed, Chris. We don't need to discuss it now, but just as I say, it's the metrics that are actually going to inform our understanding. Thank you.
I think speed of progression of individuals would be a more complicated thing for us to get. If you want us to show how long people stay in bands,
But that's an interesting conversation, isn't it, around whether women stay in bands longer than men do?
Yes,
That might actually be the key driver behind your pay gap, your earnings gap.
Yeah, and indeed I mean, it will get even more complicated because it will get into choices people want to make around whether they, you know, so it's fine to say you're staying longer in a band, but people may choose to stay longer in a band. Clearly, I mean, historically, there's been a real issue around childcare responsibilities and things like that, where people, and I've had discussions with, you know, I've had personal discussion members of my team who's talked about when they wanted to progress because, you know, it wasn't right for them. But clearly that's changing in terms of gender of who takes the main responsibilities. So I think we've got to recognise the complexity of that, and we probably can't unravel all of it, but we can look at what further metrics we can investigate. I think the earnings equally, I mean, earnings will be fairly equal because again, the grades are the same. It's the extra hours people maybe do, but there might be a differential there in terms of, don't know whether we could look at the amount of overtime different groups can do, which obviously will affect the earnings, and that might be impacted. But that might be something we can't do a great deal about, because if some people are more available to do more work, that's not really a decision we're making about what we offer people. It's about their availability to do the work. But I think if we do the grades piece, and we can go away and I can talk with David and the team about what other things we think could inform the discussion. We can go away and undertake to do that, Melanie.
Yeah, brilliant. Thank you.
Great. Thank you, Chris. I think that would be helpful just to give some further assurance. I think we just need to be careful that we don't do a lot of analysis on data that is going to be very complicated, but isn't actually ultimately going to change anything. If, you know, it's really important that we think, what can we do with that? And if actually some of it is driven by personal choice, I mean, it then comes back to the opportunities we promote, the flexible working, you know, all those sorts of other things that people make choices about. Yeah, it's a really interesting debate, and I think helpful, Chris, that you've offered us the chance to look at this a little bit further. So we'll leave it with you to decide what the scope of that is and what's realistic, and I think we can then have a follow-up conversation.
And I think the context is to have that this is obviously, as it's saying in the paper, this is a national issue and national challenge. You know, we are a microcosm of the national position. Doesn't mean to say we can't look to be the best, which I'm sure we would look to do. So we can.
Yeah, excellent. Thank you, Chris. Banu?
Thank you. Just wanted to touch on 2 points. One was Saqib's point that when we are appointing new consultants or doctors into the grades, depending on the number of years they have prior to it, they would be starting on the respective grades. So that should, we can keep a close eye on kind of what the starting points are, what that is as an exercise to make sure that we are doing it right. And the second point that Melanie was making, we were discussing something similar in the JLMC, the Joint Local Negotiating Committee, on Tuesday with the BMA. In that, the Clinical Excellence Awards might be one of the reasons for the differential gap in the male versus female colleagues. So one thing, the advantage we would think is that the Clinical Excellence Awards look at the quality and not necessarily the quantity of work. So we should not be say somebody working less than full time should not be disadvantaged if they are doing that work. What the JLNC, as we looked at, was because the CES are likely to be coming back next year, to almost make that to have that workshops, because some of the female colleagues might not be applying, saying, look, I'm doing only 6 sessions, but if you're doing a very good job, it's as good as anything else. So almost to get that to the medical staff committee, consultant committee, almost have it on the agenda and support kind of the application forms for that one. So that was the discussion from last week. I'll feedback as to where we are with it.
Thank you, Banu. It's really helpful to know that's a sort of live discussion, and I think clearly it is an important area of focus, because clearly consultants are higher earning, and clinical excellence awards is a part of that. So I think recognising what we can do in that space, I think, is really important. So thank you, Chris. Thank you for sharing the sort of report in the format that's required. I think we've agreed that we'll take that, do further analysis within the bounds of what feels reasonable, but we can take that back to the Joint Committee in due course when we feel we've got perhaps a richer story to tell on that might help us understand the drivers behind it, which I think is the sort of points that Melanie and Saki were making, really. So I think we're noting that because it is a requirement for us to review that, but agreeing further action that we wish to take on that. Thank you, Chris. So we move on then to the National Staff Survey results, and that is paper J, and I think we're welcoming to the meeting Gabby Morris, who's our staff engagement lead. Gabby's been with us, I think, for a little while, so welcome, Gabby. I'll let perhaps Chris introduce this and then hand over to you.
Yes, so I'm just going to review a couple of the headlines, and then I'll ask Gabby to go through it in a bit more detail to add some richness to the discussion. I think the important thing for us to note is that we do stay in these really challenging times. We've trailed a couple of times today how much of a challenge there is and how much staff are putting in. So it's a difficult times, but in these difficult times we have managed to stay above average on all of the key 9 people promises. We have had some, and I'll talk just a bit about that. We still have our BME staff having a worse experience, but we've talked about that again previously. And I think we need an element of caution because we have had a lower response rate, which is probably potentially symptomatic of that challenging environment. But I think with Gabby, we've certainly talked with her at length. And as we go into the next staff survey, I think she's got a lot of ideas about how we improve the engagement and increase the response rate again back to what it's previously been. Just to note on the people promises that there's some really positive elements, a couple of positive elements in there, particularly around we work as a team and we're always learning. So they've increased. Whilst a few have reduced, none of it's statistically significant. I think there is some concern for myself with the figures for the some of the res type metrics, particularly around staff experiencing harassment, which have deteriorated, not hugely, and are probably better than they have been historically. But again, that remains a real focus for us, something that we really feel isn't at an acceptable level and we need to change. So I think overall positive result for us, but lots of areas that we can work on and plans for how we engage everybody and take the engagement around the staff survey and the further gearing up of our OD programme, so that we look to improve again for the next staff survey. But with that, I will hand over Gabby, who can talk through a bit more detail. She comes with a huge amount of experience, and I think has already been working with myself and Angela and Becky to explore how we can understand things more and build things up. So Gabby, do you just want to draw a few more highlights out for the board?
Absolutely. Thank you very much. I really welcome the opportunity to share the staff survey results at the board meeting. There's some really interesting bits and pieces that you might not actually be able to pick up from the report. So one of the areas of concern that is the theme we each have a voice that counts, that has gone down slightly, but I'd like to sort of nuance out what that actually means. Our negative score hasn't increased. What it means that people have become slightly more ambivalent. There's a series of questions where people can put neither agree nor disagree. And that's the area that's grown. And that's like an early warning sign for saying, actually, this is where we need to actually put some brakes on, put some supports in place so we can not, so things don't become a problem. And this is why that measure, the neither agree nor disagree, is really, really useful. The response rates, as Chris said, is a concern. I've been looking at a number of different bits and pieces. A low response rate can be for a number of different reasons, and we use the information at the senior leadership team to get feedback on what some of those limiting factors are. And there are three main things which we're going to work on, is confidence in the process, as in confidentiality and safety, confidence in the impact. So we know that we're doing work based on staff feedback, but we've got to be stronger at making sure that people are making the intellectual connection between a program that launches over here and something that was said in a survey over there. And also access. So for certain roles, certain people who don't have ongoing access to a PC may not have the same access to give their feedback. Within that, we can do some targeted work, and that's work I'm working with Becky and Chris on. We said that the BME and staff with a declared disability had a poorer experience. There was really interesting measure on this discrimination from service users, that the majority of that, there's been an increase in discrimination based on ethnicity. And I think that's really important to note. One of the things I'm seeing from the numbers that people who are BME are more likely to complete their survey. So that may be an increased accuracy. Interestingly, the discrimination based on sexual orientation has gone down. So the change in societal pressures and things going on in society has had an impact over the last few years, but it's not being reflected across the piece. The other thing I wanted to draw out, and I know Angela has seen some of these figures, is about where we sit within our ICB and our benchmark group. Our benchmark group contains 51 organisations, and we've risen from 8th place to 7th place. So under the current conditions, that's actually a strong move. That said, the organisation that is at number one is at number one for the second year in a row with a nearly 70% response rate. We know that we've had some challenges on response rate. One of the things I'd like to say is there are teams within that who've improved their response rate year on year. So when we can pinpoint specific clinical teams who've managed to have that improvement, it begs the question is why is that not reflected across the piece? And that's where we could start doing targeted work. I've thrown in loads of information there. I would welcome lots of questions. I'd also welcome questions outside of this meeting as well.
Gabby, thank you. That's really added, I think, some richness to the paper. So really, really helpful points, and clearly, I think your point about response rate in itself, and also the target, the understanding the hotspots or the points at which things actually work well, and then where the teams or services where there's been challenges, and particularly look at how we're supporting them, sounds really critical from everything you've said. And I know that's the approach we've taken in the past, but clearly needs further focus. So there's a number of people wanting to come in, which you would expect, I'm sure. All non-executive directors, Gabby, I think, keen to hear your perspective. And I think being sort of having you here as a fresh perspective, I think is also very welcome. So Saqib.
Yeah, thank you for the going through those numbers. I guess the one that I'm most concerned about, which was highlighted, was the percentage of staff experience discrimination that's gone from the 11.7 to 15.8, while the white colleagues has gone down from 6 to 4.6. I mean, just you can see, with the backgrounds of many of us on teams, we've all got this, one team, many nationalities, and obviously as a NED, it's difficult to know what it's like to be the culture actually working in the organisation. But I'm still surprised at seeing that increase. So I just wanted to know what concrete steps are we putting in place, can put in place, what action plans to try and reverse this trend or understand what's driving that. Thank you.
I think one of the important things to actually start drilling down is where those incidents occur. Looking at the figures across a whole organisation doesn't necessarily give you the nuance. I was previously at a different NHS organisation of the same cohort, and one of the things that was coming up was that those incidents Sorry, I've just got put my secondary password in. No, don't worry. That they were seen in very particular areas, and that's quite key. Now, how those issues are dealt with is to do with the safety and security and the training staff are given in dealing with that and de-escalation, for example. But I don't think there's one single approach across the piece apart from a zero tolerance to prejudice. The interesting thing is that staff in some areas have a higher tolerance to prejudice than they should have because of the lack of capacity within service users, but the impact on staff remains the same regardless of the capacity of the patient. I'm not sure if I've actually answered your question.
I think probably, is it fair to say, Chris, that we will actually need to pick up the workforce race equality actions that we specifically are going to take in response to the survey and the data at the next meeting, because that actually is where we'll do the more detailed analysis on res. Is that right? I think that's what we said earlier, isn't it? So do you want to comment on that particular issue? Because also links to our Together Against Racism work.
Yeah, I mean, I think that definitely is, there is work we've done in terms of education. There's also a lot of work that we've described around the disciplinaries and how people are treated within that and how we focus on the informal resolutions. And I've described some of the work we're doing on that, and there's more work on that to be done. So yeah, we will need to pick up through the res, come back with that, and we've shared the res plan. So it's about taking those forward. So we will be definitely coming back to report on those.
Yes, so Saki, don't want to downplay your point because it's a really, really important one. I think just might be helpful to allow the team and indeed the Reach network to do some work together, because I think that's normally the approach on what they feel as well we should do in these areas, because needs to be a co-produced action plan that feels really important for us to do. So absolutely right that we need to understand what else we need to do in those areas, but on all of the res things, I think let's make sure we pick those up when we come back with that action plan, which we should be doing, I think, in the next meeting. Conscious that we've got quite a lot of hands up, conscious also that we are now some way behind our time plan. So I might just take, Gabby, a few comments from colleagues and then ask you to come back. So if you wouldn't mind, you and Chris maybe just kind of noting anything you want to comment on, and then we'll try and do it that way. Robin and then Melanie, please.
Okay, very briefly then. My point was not so much on the ones we've already discussed, but the two notable areas that you highlight about morale and about being heard. I'd like to see in a little bit more detail about how those are going to be addressed in the kind of proposal about what's being done. There's a lot about how you're going to measure and increase the number of the volume of reporting, which is crucial. But there was a limited stuff about how we're really going to address these points, which are clearly quite static, and there hasn't been any improvement in those. And although they may not have gone up statistically enormously, they're not rising in terms of or improving. So something a bit more about the detail of how they're going to be addressed. That's it.
Thank you, Robin. Melanie?
In fairness, I actually think Judith was ahead of me. If you want to take Judith first, but my question, sorry, Judith, my question was a simple one because I believe that Judith will delve into maybe some other areas that I'm sure I'll support. But are we still asking questions specifically about well-being? Because I would have liked to have seen the well-being results in this paper, bearing in mind it's one of our most significant organisational risks. And yet we haven't included the statistics on the well-being section and the results from those questions within this report. So, Gabby, it's I don't want to put you on the spot of saying, reel them off now by from your memory, but I would like to please ensure that the well-being results are maybe circulated after the meeting, or Chris, whatever way you wish to just help us understand those. Thank you.
No problem, Melanie.
Thank you. I think the only thing that's referenced is the people promise element, isn't it? Which is the we are safe and healthy, but not the breakdown of the questions, I think, underneath that, if I'm correct. You did?
Thanks, Rishni. I'll try to be really brief. I'd like to just circle back to the point that Saqib raised, and also the sorry, let me backtrack. First of all, really positive report, because we are, in fact, I've got a lot to celebrate. So let me just start with that rather than sort of delve into my concerns. But then I'd like to circle back to what Saqib had raised, and that specific question and that specific statistics, and also BME staff experiencing harassment and bullying from staff members. My recent service visit, which I've undertaken a few now, this is definitely borne out, and I've had discussions, some really rich discussions around all the issues, Gabby, that you've mentioned about staff feeling that perhaps because of service users acuity, that they need to sort of almost suck it up. There's all sorts of issues around how racial abuse against staff needs to be presented and logged in Datix, which is really cumbersome, so people don't bother doing it. So we've got a really big differential between what is reported and what is actually happening on the ground. And although the overall impression that I've certainly received from staff visits, from service visits, is the staff do feel supported at ground level by their managers. One of the other reasons why Datix is not used as a reporting tool is because they don't really see what comes out of it. So there are issues around that, as well as the policy that the Trust has in relation to racially abusive patients and when that comes into force. So it's a really complex issue, but I think it is fair to say that racial abuse, certainly from what I've heard, has increased against BAME staff over the last few years, and it is an issue that we need to address. And I also, just to say, I'm speaking with members of the Reach network, and it's something I raised yesterday through the Equality and Human Rights Board yesterday. Thank you.
Thanks, Judith. Angela, do you want to come in, and then we can sort of circle back to Gabby and Chris to close off on next steps?
Yeah, just a couple of points for me, Krishni. So I think it's really important to put on record my thanks to every leader in the organisation for the results that have been achieved, because it is actually a combined effort, and I hear all the challenge on it. I feel the challenge on it, but it is a good set of results, and that's about every leader in the organisation delivering that. To be 7th in our group is a significant position. In LPT, we've moved from 27 to 18. So again, improving, but I think it's important to acknowledge our thanks to all the leaders in the organisation who do that, because that's everyone. That said, I think there was a lot of challenge in there, and I really do recognise that, as Gabby said, the devil's in the detail, and that is what we need to target. And we need to be targeting that through our committees, all of the work programmes that we've described. I think that is understood, and I wouldn't want anybody to think that's not understood. It is, but I do think we should also say thank you to everybody who has achieved it. Thank you.
Thank you, Angela. Yeah, it's really important to recognise, as Angela said, and you did highlighted the sort of, in the climate in which, recognising the particularly challenging climate that everybody is working in, actually maintaining a degree of sort of stability around this has been in itself quite an achievement. Notwithstanding the challenges of addressing some of these very specific issues that people have highlighted. So in terms of next steps, Gabby, do you want to make a comment, and then I'll probably just get Chris to finish off. A brief comment, Gabby, before we close?
Yes, so certainly we're carrying on the Let's Talk programme, which is obviously trust-wide themes, targeted groups with specific characteristics, and the third level is targeted teams for targeted intervention. Also the work on response rates, looking at triangulating the staff feedback with other workforce metrics, just to say, so we can actually really identify where we need to target. We'd like to sort of fine tune some of our exec visits. They're really, really useful. And I'm joining up with Simone Dunmore to actually say, let's have those visits pre-informed with where we've got information for an area, go informed with that information. And then the wider Res and WDES and the wider Trustwide programs, I'll now hand over to Chris to cover. Thank you.
Thank you, Gabby. Chris?
Yeah, so I think, as Angela said, I do think we need to recognise that in the environment we've maintained a positive set of results. Clearly, as I trailed, some of the res figures are concerning. I think there are a lot of issues there in the disciplinary process, which I spoke about in Angela's report, and people pick up on that. I think there are issues around the recruitment, and we've got robust plans around both of those, which I think will feed in to this work. And we've got the Say No to Racist Patients, which we've piloted in one area with positive results. It's about spreading that across the organisation. So I think to assure the board that there is action in train, and there will continue to be, and yeah, we accept the challenge because we're not happy with it. We feel it needs to improve, and that's what we will be doing. So I think it is overlaying the successes that we've got alongside recognising the challenges that still exist and that we must focus on to improve.
Thank you, Chris. So further work clearly to do on that. Shall we take the I mean, in terms of the next steps, Chris, I think we've acknowledged already that the Res and DES in particular, the workforce disability and workforce race equality actions need to come back, because that's part of our forward plan anyway. Just in terms of report back around, I think it's a really good point about perhaps having a bit more insight where there have been particular issues within services when service visits are being undertaken. I think that's what I heard Gabby saying, and I think that sounds like a really good way of sort of exploring things a little bit further. Is this an area where we've got a report back anyway built into our forward plan, Richard? Trying to think, do we bring this back in later in the year anyway? I think we do, don't we?
Yeah,
in terms of an update. Yeah. So we perhaps look at that in terms of the next steps, how we've got the, as I say, in May we've got the WRES and WDES hopefully, and then in September I think there's a report back scheduled anyway. That's probably all I think we can say at this stage, and sort of ask Gabby and Chris and team to go away and obviously do all the analysis and action planning that's required around this through the programme of work that's routinely taken forward in terms of next steps. So can we pause there in terms of this discussion? And again, thank all colleagues for their contribution to the results, and also indeed supporting people with next steps. Okay, we have our quality section and we still have finance and performance and assurance to do. So I'm going to have to ask people to be a little bit sharper with contributions and comments and indeed items as we work through, so that we've got a decent chance of still hitting a deadline that we have for 12:30 if we can. So it's our quality section next. Julie? Oh no, sorry, Julia first. Anything, Julia, you want to cover with regard to the assurance report from Quality and Safety?
Thanks, Krishna. You'll just take it as read. You won't be surprised to see that monitoring workforce safeguards remains a concern. But just to say that links to several areas on the organisational risk register. And we had the opportunity to look in detail at mitigations for the then potential strike actions, which I think we've spoken about earlier. And just to highlight in the safeguarding section, a lot of that was relating to a new requirement for increased training at level 3 for safeguarding adults, and we have some gaps in compliance with that. And lastly, that there was a safeguarding internal audit which has been reported through the audit committee, but we will be seeing some updates on actions just for completeness around safeguarding, but the rest is taken as read. Thanks.
Thank you, Julia. Any questions on the report or comments? No, okay, thank you. So we move on to patient safety and learning report, which is paper L. And Julie?
Thank you, Krishni. I'll take the paper as read as time short. There are just a couple of things I'd like to say. So as a board action, to understand a little bit more around why investigations are delayed, there's further information in the private patient safety report this afternoon. But these are things like Angela's already alluded to the pressures on our services, both clinically and corporately. And this is around, this is having an impact on investigators because our investigators are also coming from clinical services, as well as us having some investigators, but they investigate SIs and complaints. We get delays before annual leave and sickness. We are on it. We do have bank staff in place, but actually it is difficult at times to find bank staff to do these investigations because we do need a certain skill set for this. So I just wanted to bring that to the table. And the only other couple of things I wanted to bring is some good practice. So we talk about a pressure ulcer group across the group. But actually, there's been some discussions this week around working across the ICB on pressure ulcers as well through patient safety. So we're pulling it all together on different angles around pressure ulcers. So I think that's really good piece of work. And the other thing is, and G might quickly want to come in on this, but I know time's short, around violence and aggression towards staff. Jean's team are doing quite a bit of work on this. It's not in the report because this is a patient safety report, but just wanted to assure members there is work going on in the background.
Thank you, Julie. And I think that's referenced actually in the Julia's committee report as well, that the work on violent incidents affecting staff. Julie, one question for me, and obviously, I don't want to rush through to the extent that people aren't asking questions, so do please come in if you've got any key points you want to raise. But is there a concern about data quality around pressure ulcers? Because there's quite a lot of validation work to be done, it sounds like, or that's what the report infers. So I just wanted us to be really clear what I think the suggestion is that some of the pressure ulcer data just needs validating and auditing, but does that suggest that we can't be confident about the data? Can we just be clear about that?
So we normally have a process in place to do this. We are behind with it, and you will remember, and I know Julia's challenges this through the Quality and Safety Committee, that we'd asked the district nurses to pick this back up because they used to do it. And the tissue viability team had picked up. So it's not actually an audit as you would see it, but we review the data. There's two sections, I understand, to a DATEX, and we're talking about the second part of it. And we would normally look at those. But we have asked the Tissue Viability Service to pick this back up because, as it says in the report, I think we're on November. And actually, we need to pick that back up and get us more up to date. And as it says in there, the Tissue Viability Service have also been working extra hours and weekends to do this because it is a tiny team. But we have asked them to pick all the work that had been transferred back to district nursing back because district nursing, as we know, are under extreme pressures.
Okay, thank you, Julie. That's helpful to note. Are there any other questions or comments regarding the patient safety report, which is an important report? Julia, I think you tend to go to this committee, don't you, anyway? So I don't know whether you want to add any other points to the report.
Yes, thanks, Krishni. Just so people that I know we're a little bit short of time, but just so that people know the additional assurance that we do take, Patient Safety Committee looks at all this detail in great detail, and as Julie says, we do challenge on multiple areas. But also the good practice that Julie's drawn out. I mean, I've watched over the last year a real focus on learning, particularly pressure ulcers, newly around people who fall, violence and aggression, as you just said, Krishni, and particularly around medical devices and our assurance, there's been a huge amount of work in the last year. So and just lastly, around thematic reviews, they're really important, and they show that we're not just looking at individual incidents, which dovetails into the National Patient Safety Strategy approach, and we've been doing that for some time as an organisation. So the level of assurance for me is through sitting through that safety committee, quality and safety committee, also get a chance to do a bit more strategic overview, and then of course it comes to board. So we have asked a great many questions around the detail, but just wanted the good practice to come out too, because huge amounts of work going on in the background. Thank you.
Great, thank you, Julia. So we note the data that's provided and the assurances in the report, and helpful, I think, to have Julia's commentary as well on the work of the Patient Safety Committee, on which she sits and contributes to as well. So monitoring workforce safeguards, Julie.
Thank you, Krishni. I'll take this report as read. There's just a couple of things I want to raise here. Is this time of the year I always bring the most up-to-date flu performance figures, don't I? So you've got the percentages in the report, but I've got the figures as of the 28th of this month, because the programme obviously comes to the end tomorrow. So I've only got the trust-wide ones for flu, and at the moment that's reported as 38.8%. And the COVID booster compliance trust-wide is 19.1. So there has been a small increase. I haven't got the national data. So obviously we report in the report on our local data and the national data, and the report explains the difference, but I haven't got the national data, so I can't report on what that tells me. Julia referred earlier to a risk around level 3 adult safeguarding. This came out pre-COVID, and we need to do a lot more around our compliance. There was a report that went to our EMB, our exec board, on Monday, looking at getting this on ESR, having extra training in place. So we are planning to get 3 sessions a week in. It does take a day to do it. It has a national it's not national training, but there's national expectations of what have to be in the training. So even though we've also got an e-learning package, that will take people most of the day as well. And there's not a lot we can do about that. So the other challenge for us is going back to the pressures on staff, is actually getting staff to actually attend this training. And I know we've got a commitment for operations, but and the pressures that are going on, this is going to be a challenge. So I just wanted to bring that to the committee. The other piece of work that we've got underway is we're doing a review of our international recruitment programme at the moment. Is there any learning for us, any feedback from our international recruits, etc.? And we obviously are linking in with LPT around what they're doing. And very interestingly, they have linked into Ireland around mental health nurses. So we're going to link up with what they're doing around that, because I think that's an interesting piece of work going forward.
Thank you very much, Julie. I think good to note the comment about a level of stability over the past month in terms of some of the in some areas. I think that there's sort of references around that in terms of workforce. So I think that was good to know. Are there any comments or questions on anything Julie has highlighted or anything in the report? Okay, nothing specific. So we've got, I think, clearly that the workforce risks remain high, and we recognise that, and the mitigations are in the report. The process for continuous review remains in place through various mechanisms that are in existence. But I mean, helpfully, and I think actually on. So, good reflection, I suppose, that as a board, we've already spent quite a lot of time talking about workforce issues through the staff survey, etc. And I think we have got in one of our items that, the talk about the future meeting, the opportunity for us to now explore some of these issues in a bit more detail in that future meeting. So we'll come on to that shortly. Thank you very much. So we acknowledge that report. And then finally in the quality section, the complaints report, Julie.
Thank you, Krishni. I'd like to take this report yet again as read and just highlight a couple of areas. So we did agree with the board that we would try to return back to our 25-day target, which was pre-COVID. During Q3, we were looking at 35 days. It is a struggle for the team, and we will find that more in the Q4 report, because in Q4 we've had some sickness within the team. This team are suffering from the COVID effect, and I've started some work with the team around quality improvement. I actually started on Monday and using some of my quality improvement skills as a quality improvement practitioner. We've been doing some process mapping. We will be looking at demand and capacity and using some other techniques to really look at the systems and processes in the team. And is there a place for digital technologies? I don't know. We want to look differently at complaints, so that piece of work has commenced. As the board asked, I think it was at the last meeting, we've put more information on patient feedback. At the moment, we use I Want Great Care, don't we? So we've provided more information on that. So they were really the areas that I wanted to bring up through this report.
Thank you, Julie. Any comments or questions on that? Judith?
Thanks, Rishni. Thanks, Julie, for the report. I've got two questions. One's in relation to a clarification. I'm not sure I quite understand the definition of complexity of complaints. If you could just, it doesn't have to be right now, but I'd just like to understand that. And secondly, I was just wondering how we can bring the complaints and PALS data into our EDI work. Do we have data as to the protected characteristics of those making complaints or making PALS referrals? And I'd just be quite interested in that. Again, doesn't have to be an answer right now. Thank you.
Julie, do you want to comment on either of those today?
Yes, I probably can. So complaints and PALS into our EDI work, we can certainly start reporting through here. Some data. I'm not sure the level of data we collect, but we can certainly start reporting through here because I think that's a really good point. So we can start doing that. The other thing is around complexity. Very quickly, what we mean is they are not straightforward complaints. They might involve other organisations. So we get complaints in that will be for us, perhaps the local authority in KGH or NGH. It doesn't matter, but it's more than one organisation. We also may see that we've got several teams across the trust that they're complaining about, and also we have complainants that will add to their complaint, or it's a more historic complaint, or it may have several versions of the complaint, and they may be coming back to us time and time again. So they are getting more and more complex. And some of these complaints may even be longer, may go into, we've seen some of 35 plus pages as well. So they are quite complex at times to look at.
Okay, thank you.
Thank you. Thanks, Julie. So I think, clearly, I think Judith's asked about breaking this data down by basically by protected characteristics is a really good improvement opportunity. Julie, recognise that's not going to necessarily be a quick thing to fix, but perhaps we can ask you to feed that into your sort of improvement plan that you were talking about as another step to take, which I think would be really valuable. Julia?
Thanks, Krishni. Just another angle, really. I think Julie's right to highlight sort of capacity within the team, but certainly also for me, we have a really strong system in the triangulation meetings that happen every week, I understand, and then certainly looking at monthly data, triangulating patient safety incidents, patient experience information, quality, etc. But that's under strain at the moment, I think, particularly around operational pressures, and of course then when you have your support teams also under pressure, it's a bit difficult. So I think she's right to highlight that. We're aware of that and certainly are seeking to sort of support in any way we can.
Thank you, Julia. Melanie?
I think this is such an important area, as I think we all agree, and so much rich content in this report. I guess my challenge from an assurance perspective is I still find this one of the most difficult reports the board receives to digest and actually gain a kind of a strong understanding, because I think there is an awful lot of content in it, and I just wonder whether or whether there is already work afoot maybe to consider how we could use more trending, more visual representation, more tables and charts rather than paragraphs with statistics hidden within them. It might just be me, in which case just tell me to shut up. But I do think that we could develop this report to give us a greater oversight, because the other thing is we split it between all these different parts of feedback. But in actual fact, whether it's from PALS, I want great care, or complaint, doesn't really matter. You know, what matters is what is the patient saying. I don't think we actually need to focus so much on the source of that as much as bringing it all together into what is the patient telling us, what is a service user, a carer telling us. So I'd just like to maybe challenge us ourselves to kind of think of a way to develop this report into something that's more accessible, consumable, and indeed actually provides us greater assurance.
Maybe we can ask the Complaint Review Committee to look at that, because I think, I mean, if I'm right, I think we do need to actually note the actual numbers of complaints. I mean, there will be a requirement for us to note specific data in public, and I don't think we can merge it. Just you know, so there will be a requirement, to report the numbers of complaints in public, etc. It's just thinking about how we make best use of it and what we draw from it in a sort of thematic sense, I guess. And I think in that sense it's absolutely right that we focus on common themes that are emerging from it. So Julie, do you want to make a comment about that?
Yes, because I think if you go back probably maybe pre-COVID or during COVID, we used to do 2 pages of appendix with a lot of information on, and then we would do a very short report, and then we were asked to put those into the actually into the main report. So we obviously need a happy medium somewhere. We've obviously gone too far the other way, so we will review it through the Complaints Review Committee.
Thank you, Julie. I think the only other thing I just wanted to comment on was really just I want great care, because I think, I mean, it's good to see that there are a number of actions in train. I just wanted to sort of really reflect on the fact that it's been a very important part of the evidence that we've provided to the CQC in the past about our responsiveness, our, you know, the patient experience, I guess. So making sure that we really are focusing on outstanding, and you know, I'm sure this is part of the pressures that we've been recognising that our staff have been under, but certainly increasing feedback and responding to the feedback and all of those things feels really important. So whilst I can see there are a lot of actions in hand, I think clearly, I think we'll need to see the outcome of that in terms of sort of improving the performance of the feedback loop, if you like. And also, I think we should just note that the Friends and Family Test score has deteriorated, which, you know, is something just to, hopefully it's a blip, but it is just something we should, you know, ask the committee just to obviously monitor and report back on, because and maybe we need to do an SPC chart on that, so we're not reacting to a blip. But I'll just sort of mention that so that we think about how we report back on that. Really, is that okay, Julie? So a couple of things maybe to go back and have a look at, certainly in terms of ethnicity data, or data in terms of protected characteristics, I think, rather than ethnicity specifically, but also just really the report format, and as part of your general review, I think it sounds like a good opportunity. Is that okay?
Yeah.
Great, thank you very much. Right, we move on then to our finance and performance section. So we've got a couple of assurance reports, firstly from performance and then from audit.
I think that's me then, Krishna, yeah?
Yes, please, Scott.
No problem. So again, in the interest of time, I'll take the report as read. I will probably choose not to focus on the financial elements at this stage, given where we are in the financial year and things move quite dynamically at this stage. So I'll move on beyond those just now. In the committee itself, we had a really good session led by Dave that took us through where we were in terms of, our delivery of improvement activities through ICANN and how that is now passing as we move beyond our engagement with Newton Europe. What came across really is it feels like it's a really important stage in the development of the initiatives that were driven by ICANN, and it feels particularly important that we get an opportunity to bed those in properly in our BAU activities across the system. And I think there was concern, that's the reason why it was reported as an amber in the report. There was concern that there wasn't uniformity of that opinion in regard of the ICANN successes across the ICB, and I think we've heard some dialogue about that already in committee today. Won't touch on performance dashboard again. We've got another element of the meeting that touches on that a bit later on. We did receive a new format for the workforce dashboard, which is following the format developments for the performance dashboard, inclusive of SPC charts, etc. And I think that was well received by the committee, and already, even at a first viewing, gave us an opportunity to draw fresh insights actually and ask sort of reinvigorated questions in that area. So thank you to Chris and AJ and others, right, who were involved in the improvement of that reporting format. I suppose the last comment I'll draw out, Krishna, was that this was my last committee as chair, and I'm passing the baton on to Judith. And I think that actually helpfully, I think, coincides as well with us moving on beyond the reporting format that we're feeding back on here. I think it gives the committee and Judith a really great opportunity to sort of put a fresh stamp on it and drive additional focus areas out of the committee. So I'm looking forward to continuing to participate in it in the committee, and maybe taking that one half step backwards at least as I pass the baton to you as we go forward. But that was it from me, Krishna. I'm happy to take any questions.
Thank you, Scott. Judith's smiling, so obviously it was agreed. No, I know it was agreed, but but of course you are staying as deputy, aren't you? So you'll be supporting Judith and still playing an active part, I'm sure. Any comments or questions, David?
It was just to say, and Judith just popped into chat, but we did have a conversation in Performance Committee to say thank you very much, Scott, for all of your hard work and ways of going, but very conscious that that doesn't get recorded in the public meeting, and we should do that today.
Thank you, David, and thank you absolutely, Scott, for chairing it for quite a long time now. I can't quite remember when we handed the baton to you, but it's a while ago. So thank you very much, and you know, it's both a sort of loss and an opportunity, because you know, as ever with non-executive directors, you know, part of bringing, you know, part of why we are here to bring a fresh perspective as well. So you did, hopefully will bring that, but with your experience still bearing down on the committee. So thank you so much for doing all of that. Any other comments or questions on the report? Okay, thank you. So we move on to the audit report, assurance report. Saqib, anything you want to particularly highlight?
So just again, in the interest of time, so two things that I wanted to highlight was one, the Involvi payments that will be looked at. So Richard's trying to see how we can progress that, because potentially we may be in breach if HMRC were to investigate. In terms of capacity, supporting Richard and the team to make sure that we're able to achieve our work that needs to be done in anti-crime. And then finally, on the internal controls, the seeker, the other amber that's at the bottom there, just to make sure that any outstanding tasks are completed. I suspect they won't be by the end of March, but again, to have the capacity to make sure that those are done in short time and that we are kept abreast of any delays that will stop that happening, because otherwise it will have an impact on our internal audit opinion. So they're the three things I wanted to highlight. Thank you.
Thank you, Saqib. Any comments or questions relating to that? So some important actions, it sounds like, that need to be just taken forward and supported. And certainly that's been highlighted in the report. So we do need to note that. And Saqib, perhaps we can discuss if any further support is needed to take those things forward. Okay, thank you. Then integrated performance report, Dave.
Thanks, Krishni. And just to echo, thanks to Scott for his always kind but always diligent oversight of the work of the Performance Committee. I'm pleased to say that we've got a continuous improvement programme in place around SPC. So you'll note in the governance section of the pack, we talk about an organisational reporting framework, which we're aiming to have in place by next month. Using this month's data, so that will bring together all the domains of quality, finance, performance, workforce, and others into one overarching organizational reporting framework that will give us quite a deep, granular view of where we have issues across the 100-odd services that we currently run. Bearing in mind that we only report on a fraction of those services through this performance report, the IOR is intended to give us a more heat map orientated view of where we might have challenges or issues within services that need to be addressed with some focus. So that's quite an exciting development. We committed to doing that, if you recall, 6 to 9 months ago. So I'm really grateful for the team's efforts in getting that mobilised, and there's a phased approach for those that have read it outlined in the pack. In terms of performance more generally, I guess just probably draw out 3 key areas. Continued work in out-of-area bed provision for mental health services. There's quite a concentrated programme now in place. We've set a trajectory for next year, which talks about looking to get down to 0 in Q1, allowing for some seasonal spikes in Q3, but overall a general sense of very low numbers across the year, with 0 being the target. So work is continuing on that, and we will be reviewing our spot purchasing arrangements with providers to see whether we can explore other ways of introducing capacity into the system and letting that form part of our value programme proposition for out of area. Second area relates to MSK and ongoing wait times. Jean will be handing over a task and finish group that's in place to try and get ahead of some of the waits there. This is reflected nationally, I have to say, in MSK services more generally. And again, we're impeded by some of our recruitment difficulties, but there is focused, concentrated work happening to ameliorate that, and always with safety at the centre of that work. And then finally, there is positive movement in some of our CYP services. It's not statistically kind of empirical yet, but there does seem to be quite sustained improvement in some of our urgent and routine activity across CYP, eating disorders and others. I have escalated within the ICB Performance and Delivery Board the overall risk that we hold as a system for CYP services, and we've had a risk summit which we've updated on previously, and Julie is leading on that work for us internally in NHFT. But there's quite an external piece of work which I've highlighted into the system, and I know would be flagged at the ICB, the Integrated Care Board itself, as one of their top risks at the next meeting. So that's all I wanted to say on the performance report. Thanks, Krishni. And thanks, Scott.
Thank you, Dave. Any questions or comments for Dave? Dave, just one thing from me, that under mental health inpatients, there was the continued and increasing delays in discharges, which obviously exacerbate the out of area placements. I just really just wanted some assurance about the system. You know, there's always a risk, isn't there, that delayed discharges in mental health services, inpatient mental health services, is not the impact of that is not understood in the same way as in acute, or doesn't perhaps get the same focus. And I just wondered whether you know, there is a good sort of system level of input and support for that and for addressing that, really. you want to come back on that?
Could I bring Anne in, please, Krishni, who I know has been involved with partners on that?
Yeah, we've had quite an extensive programme. It's quite complicated in mental health because people's recovery is not always a straight line, and you can take some steps back when feelings around what the community exit plan is going to look like can cause some sort of levels of relapse. So the timings are really critical. So they have a number of bed meetings which system partners join on a sort of a team level during the week, and then we have a escalation meeting where we go through every single case. What that's led to is really a reflection that the provision we've got in the market in the community is not sufficient in not just in numbers, but really around the sort of placements we've got and what's suitable for our service users. So we've just kicked off a piece around commissioning with the local authority colleagues about thinking about what we know now what those placements need to look like from a series of escalation meetings, but it's actually how we take that to the market and how we do it together, which really leads into the next phase of the mental health contract about how we work together. So there's been quite a shift in that system working in the last month, I'd say. Hasn't taken away the issue, but it's made it an understood issue between all of us, which I think has been really important.
Great. Thank you very much. I think that's helpful to note, really. Melanie, did you want to come in? No. Okay. Thank you. So I think, as ever, I mean, this report has developed really well, and we get a really good insight, I think, from the analyses that are shared with us. So thank you for that. And we note the performance and the assurances that have been provided. So we move on to the final section of the agenda, which is our assurance items. So we start with paper R, which is the group highlight report. David, do you want to make any comments about this?
All I was going to say was green rated as we go through everything. I think the bit that I'd flag and draw to people's attention is that as we go through looking at value and thinking about efficiency, the real opportunities about what we can lever out as a group will be clear and evident, and that will be where we'll want to invest some further time to bring out those efficiencies and get the best value from our services.
Okay, thank you. Is everyone happy to note that report? Because actually that was the summary, I think, of the papers anyway, because we were unable to meet together for the last meeting. So we'll note that and move on to the what good looks like, digital maturity assessment submission, which is paper S. And I think that's Dave, but it's basically, if I understand it, we're just being asked to make a decision to delegate the approval for submission to the performance committee, Dave, if I'm right.
Precisely, Krishni. Thank you. It's a requirement that we have kind of board level sign off, but we're asking for that to go through performance committee in May.
And is that just because it needs more work to be done before we can submit it, and the timing just works?
It's the timings, making the timings work in terms of what committees are available to sign it off.
Thank you. So Judith, in your new capacity as chair of performance, are you happy for and the board is happy to delegate this to the performance committee?
I'm happy, thanks.
Great. Everyone else supportive? Okay. Thank you very much. Okay, so the next item is the feature of the joint meeting performance and safety and quality committees, which is paper T. And this is really the summary of the review that was undertaken and our proposals that have been socialised extensively and discussed, I think, with non-executive colleagues as well. Richard, is there anything you particularly want to bring to our attention?
Thank you, Krishni, unless Chris has anything to add.
I'm happy to take the paper as read, if that works, Krishni.
So please make comments if you wish. I'll just make I think couple of observations of things that I've spoken to Richard about. I mean, I think first of all to say we've already identified through the course of this meeting some topics that I think it would be helpful for us to explore, which I think is really good because it highlights the potential value of the meeting. There's a kind of reference, I think, to a work plan, but so far we've sort of already semi-created a work plan by talking about the potential to deep dive risk for the timely and the quality of data, timeliness and quality of data. We've talked about gender pay gap as an example, and potentially I think Richard, I think, commented in chat that we may want to look at the staff survey and perhaps response to that as part of a kind of wider issue as well. So we can develop a work plan around that. What I did want to say is that because I was conscious that we haven't quite onboarded our new associate non-executive directors or not completed their onboarding, and indeed Tim has officially yet to start, that actually we might need some volunteer from within the current group to chair the May committee performance, the joint committee, almost in its current format, and then for us to agree, I think, the work plan. I think that's what we discussed, wasn't it, Richard? Agree the work plan and then begin to think about who can take up the role, because we do want to establish a permanent chair, really. So that's the conversation we've had. Did you want to come in on that?
Sorry, I'm having real problems with my hands today, so it's flashing on and off for no reason. But you asked for volunteers, and I'm very happy to volunteer for that May session.
Perfect. That's great. I love getting volunteers. That's helpful. So thank you, Edith. Yeah, that just allows us to make the transition work. So we're, obviously being asked to endorse the proposals within the report. We do need to kind of make a transitionary step, which is the discussion Richard and I had about how we do that. I think we can perhaps, I think the plan was to sign off the work plan and then hopefully I can also be in train thinking about other chairing arrangements for this committee in the meantime as well. So is everyone happy to endorse the proposals as outlined? Are there any comments or questions before we do that? No, great. Thank you very much. So that's been a really good piece of work, I think, to get us there, Richard, and thank you for your efforts in concluding that. And then the annual effectiveness review, which is paper U of the board and its committees. Chris, do you want to comment on this at all?
No, I think we can take this as read as well. Christian, I think it follows the format we've used previously, but with some enhancements. So it seems and recommend it to the board.
Thank you, Chris. So I think the main thing is to ask some more searching questions, isn't it? Or different questions to take the learning and the review and improvement to another step. And I think probably worth saying that we also, Richard and I, discussed that for COG, we might want to wait until September, Richard, I think we said, because obviously we've got a lot of new governor colleagues coming in. So just really worth noting for the board that, clearly, I think we've already shared this with COG in a report, but the potential for doing that slightly later in the piece felt appropriate, really. So is everyone happy to support the proposed approach and the questions that are highlighted on page 2, questions that would form the basis of the review? Everyone okay with that? Supportive? Good. Okay. Well, we have cantered through those last items. I hope without compromising quality, because that's really important. Chris?
Yeah, I've just got an item of any other business when we come to it, Christian.
Okay, thank you, Chris. So we have the item for information, which is our board declaration of interest, paper B, but that's there obviously for noting, but please do make sure your entry is up to date. So the any other business section then, Chris?
Yeah, just it's okay with Angela. I was going to update on the directors' roles who support exec directors. People will remember over a period of time we created director roles that have supported both the joint roles and other directors in the organisation, and they've attended the board for a period of time, which has been a part of their development and positive development. I've seen a number of people have moved from interim roles into acting roles, and let's spare her blushes, but for example, Anne has moved from the director of mental health into the interim role for the coup. So I think it's been a fabulous part of our talent management and our development. Having governance terms, we do need to be conscious that the exec directors are the members of the board and the other members of the board. And it seems timely now, as we've bedded in after COVID, that we should decide that we wouldn't automatically have them attend the board. If there are papers to present or there are development opportunities for them, then they would attend, but they wouldn't automatically attend. And similarly for the level 1 committees. And just really to report that to the board, and that's I think a positive step in using the development, but then ensuring that our governance is on the right track as we move forward for the longer term. But I would, express my thanks to all of them, and I'm sure others would wish to do that because they've made a massive difference in stepping into these new roles.
Thank you very much, Chris, and I'm sure we want to echo your comments on that, and also thank Jean again, because this is the last time we see her here in this format, but we know we'll be seeing you anyway when we do our joint board development, etc., with Leicester Partnership. So wish you all success, Jean, in your new role. So thank you, everybody. Bring the meeting to a close. Just any quick items of review, obviously a little bit tight for time today, but I think there was quite an extensive discussion on some topics, rightly so. So I hope that was appropriate in terms of allowing that discussion. We had a fantastic, really insightful patient story, I think, as well, which everybody, I think, found valuable. And probably one reflection from me is I think because clearly there are some people discussions we want to have, it feels very appropriate that we've signed off the new terms of reference, because actually I think that would help us with as a board just to allow a bit more time for some of those discussions to happen in the Integrated Assurance Committee and report back to the board and relevant committees from that. Any other quick points of feedback before I close? No. Okay. Thank you, everybody. So going to close the meeting.